Yes.
Ritu ma'am?
Yes.
Yeah. So a very good evening to all of you. And after a fantastic start for the year 26-27 yesterday, today we welcomed you to the FOGSI ICOG Masterclass on Fibroids, which is very, very relevant to our clinical practice. And at the outset, it's a distinct honor to introduce a leader whose vision has constantly guided us towards excellence, a champion of our core values, our esteemed President, FOGSI, Dr. Bhaskar sir. I take great pride in inviting you, sir, to share your invaluable insights with us.
Thank you, Dr. Ritu. At the outset, I would like to congratulate ICOG under the leadership of Dr. Sheila Mane, Dr. Sadhna Gupta, Dr. Pratik Tambe, and all the governing council members for continuing the good work which has been going on for several years and taken to a new height last year by Dr. Parag Biniwale and Dr. Sanita Bhalerao, along with Dr. Ashok Kumar. So these master classes are of immense value to practitioners and students alike. And over a period of around 3 hours, it covers everything on a subject. So today on myomas, a very common condition, we have a very, very comprehensive and exhaustive program which covers everything from classification to imaging to medical management to surgical management to I would assume a case-based panel discussion. So congratulations and I wish that it will be a very useful program. Thank you for having me.
Yeah. Thank you so much, sir, for your blessings with your valuable words. And now it's my proud privilege to welcome our ICOG chairperson, Dr. Sheila Mane ma'am, a leader who not only dreams of a bright future, but actively builds it. Welcome to you, ma'am, for your blessings.
Yeah, thank you. So I'm so happy to see that so many people have already joined today. And as Dr. Bhaskar said, fibroid, which is so common now today in our gynec practice. And I'm sure that it will be a very, very valuable academic knowledge for everybody, whoever is attending. And the dilemmas will be dealt in panel discussion because there will be different case scenarios. And I'm happy to see that so much of faculty is interested and most of them have already joined. I welcome Dr. Sujata, Dr. Rajashri, who are not in our governing council. So I thought I must say welcome to them on behalf of ICOG. And I think there are many more who will join later. So rest all, once again, I welcome and wish to conduct more and more academic programs with everyone, and we see to it that we try to achieve better and better day by day. And thank you, Ritu, for those kind words. Thank you.
Thank you, madam, for those inspiring words. And now it's time to introduce the driving force behind this organization's success, a leader with an unparalleled dedication, and that's ICOG Secretary Dr. Pratik Tambisa. Awaiting your inspiring words.
Can we have Dr. Suvarna Khadalkar and Dr. Sunita Tandurwadkar first? I can speak last at the end.
Okay. We are deeply honored to have with us today our immediate past president FOGSI, Dr. Sanita Tandulwarkar, madam. The rocking year that we all had witnessed, and I must say that she is very, very dynamic, a strategic architect, and a dreamer and a doer. A warm welcome to you, madam, for your blessings today.
Thank you. Thank you so much. For last 1 week, I did not have 8 p.m. podcast. Yesterday, Sheila, I refused to join. But then in the night, your phone call made me compulsory join. I'm so glad to see you all, the way FOGSI and the way ICOG function. It's fantastic. Suvarna, love you. I'm seeing Suvarna after Delhi now. And Pratik, thank you so much. Thank you. You as a secretary will do wonderful job, I'm very sure. Ritu, love you all. And what is amazing always, I don't know how, but the attendance for the any ICOG, I don't know ICOG kya khilata hai unko special. It is so high. Hi Bhaskar. I hope you are enjoying and rocking your presidency.
Hi.
Thank you.
So
Lovely
this is
to
the
see
first time
you.
you are, Sunita, I think this is the first program you are attending as the immediate past president.
Yeah, that too शीला ने रात को फोन करके वार्निंग दिया कि please have come, and I don't know how come my ICOG student came and she said, Madam, you did not join yet. So I said, okay, I will. But anyway, lovely to see Bhaskar. You are rocking all around. I see the vibrant FOGSI, the vibrant Secretary General, the vibrant ICOG. Thank you, Sheila. Thank you for your love. And I'm seeing Manish Pandey here. And I'm so glad that
Yeah, I
he's
wished
back with
him.
you.
I saw him in the beginning and I'm so happy to see him. Yeah.
Thank you. Thank you.
And
Love you all.
thank you so much,
Thanks.
Sunita, for joining,
Thank you.
Thank you very much.
Thank you.
Thank you so much, madam, for those very, very kind and loving words. And we always, always are so happy to have you with us. Thank you so much for joining, ma'am. And now, a warm welcome to the stalwart with a passion for innovation. And that's our Secretary General FOGSI, Dr. Suvarna Khadalkar, ma'am. We would like to have your words of wisdom, madam.
Thank you so much, Ritu, and the entire ICOG team led by Sheila Mane and the president, Dr. Bhaskar Pal. Lovely seeing Sunita after a long break. Sunita, I'm sure you need some time of yours to relax. And this is the entire, I see each and every one who is so much passionate about ICOG activities. The newly appointed ICOG secretary, Dr. Pratik. I can see so many of Sita, then Kiran Pandey, Deepika, then Mitra, Meena, my God, everybody is so passionate. And I feel, as everybody said, fibroid is a very common problem. It is a age-old problem also, but we come up with new solutions. And that is the exact reason why we keep meeting every, I think, conference, every CME. There has to be a lecture on fibroid and some innovative procedures, some innovations that everybody will display. This is how I manage this difficult case. I remember Sunita's orations where she had done fibroid mapping and how she dealt with difficult fibroid cases. I'm sure this CME is going to be very, very helpful, and I'm sure equally innovative ideas may be exchanged with all the audience. And I once again thank Sheila for her second program of the year, and the entire governing council. I want to put here on the record, I don't know, when I was the governing council member, we were, not doing all these activities online. Maybe this COVID has taught us. But governing council hardly participated in the academic activities. And I think a few years, Dr. Mandakini Meg, Dr. Lakshmi, and the past ICOG chairs have been involving governing council members actively in all the activities of ICOG. That is commendable. And please continue to do that so that we all feel ICOG fellow. That fellowship must build within ICOG college. So I think this is an important thing, because otherwise we were feeling left out when we were the council members. I see all the council members who are so much interested in teaching, and they all have joined. So wish you all the best for your program once again. Thank you.
Thank you so much, madam. Suvanda, madam, thank you so much. And we are really privileged to have with us today a person of remarkable wisdom and experience, who is the Vice Chairperson ICOG, Dr. Sadhna Gupta, madam.
Thank you, Ritu. So it's like a combined celebrated day for all of us. And Dr. Sheila Mane has just taken charge as a ICOG chair, and the whole year program is packed not only with the academic but a lot of the ground root innovation, groundbreaking experiences. So we welcome as a vice chair all faculties, all delegates, and like our all previous Dr. Sunita, Dr. Swarna has told that the fibroid is so common, and we are today, once upon it was only surgery or ignoring, and now we have a lot of medical diversity of surgical options and the relation with the IVF, and that has made
age-old problem, very, very challenging. And with all masters as a speaker and as a chair, this program will be a great learning and the sharing platform with all the people who have joined. So once again, very warm welcome. And we look forward to great learning, not only in this program, but throughout the year with a very dynamic chair as a Dr. Sheila Mane and very meticulous secretary as Dr. Pratik. And of course, we all governing council members as well as the all other office bearers. So thank you very much.
Thank you. Thank you so much, madam. And now we move to our very, very dynamic Secretary ICOG, Dr. Pratik Tambe, sir.
Thank you very much. I'll just speak 2 sentences. My gratitude to our convener, Dr. Sarita Bhalera, who is the Vice Chair elect of ICOG. She couldn't be here, but she'll join us very shortly. The 2 coordinators, Dr. Ritu Khanna and Dr. Richa Singh, have done a fantastic job. Throughout yesterday and today's program, we've made as much effort as possible to bring you the best faculty and involve all the governing council members. Hope to see this enthusiasm and unified spirit throughout the rest of the year as well. Back to the conveners and request you to take it forward.
Thank you so much, sir. And I hand over to my co-convener, Dr. Richa Singh, to continue the scientific program.
When we have a inauguration, I think it's a prayer.
That is actually the first slide, ma'am, but we skipped that.
Yeah, we can have it now. Yeah.
So,
Shreya, you can play that, please.
Good evening, everyone. After a great inaugural start yesterday of our academic meetings with eminent speakers, Dr. Pele and Dr. Pandit, today we continue our series of webinars. And today we have it focused on fibroid uterus. And the topics which are selected for the lectures are so good that they comprehensively cover the entire management of the fibroids. So for the first session, I would like to invite our chairpersons, Dr. Kalyan Banmade, CV, please. Dr. Kalyan Banmade is the President, IH 2025-26. He has been the Secretary for the year 2023-24, Chairperson Infertility Committee, AMOGS, Chairperson Public Awareness Committee, FOGSI 2019-22. And he is the Executive Managing Council Member of IH, Maharashtra, ISAR, AMOGS, President Latur, OBS and Gynae Society, Organizing Chairperson AMOGS at Aurangabad, Organizing Secretary for MRCOG exams, Organizing Secretary for the first Yuva IH 2017 Endo World Conference, Organizing Secretary Pride 21. So we welcome you, Kalyan sir. Dr. Meena Samant. She's the Director and HOD, Department of Obs and Gynae, Jai Prabha Medant Hospital, Patna, Governing Council Member 2023-25, and recently she delivered her talk in the ICOG symposium at AICOG. She is the past President, Patna Obs and Gynae Society, FOGSI Clinical Research Committee Chairperson, Vice President ISOPAP 2023, Secretary General ISOPAP 2018-22, and she is besides that she has contributed many chapters and articles in the journals. So we welcome you, ma'am.
Okay.
Our third chairperson, Dr. Tarini Taneja. She is the President ISPAT Delhi State, Finance Secretary South Delhi, GC member ICOG 26-27, and we all know her very well. She has also won FOGSI Legend of Gynecology, FOGSI Professor Kutti Lifetime Achievement Award, Nari Gaurav Award. We welcome you, ma'am, to chair this session. So the first speaker of today, I request our chairpersons to introduce the first speaker of today, Dr. Kanchan Prasad.
As a chairperson, can I just say a request of everybody that let the CV be brief, okay? So that we can go on to the scientific program. Okay, for everybody, we can just take the important positions and proceed. Okay, yeah.
My Dr. Kalyan is here.
No, I think he's held up in a
Yes, sir.
surgery. He had specifically requested for this
Okay.
session, but I don't see him joined yet.
Okay, so I'll take this opportunity to introduce Dr. Kanchan Prasad, who's professor at TMMC NRC Muradabad, and she is a fellow of the Reproductive Medicine Diploma ART and received many awards and accolades.
Thank you. Thank you so much, ma'am. Thank you.
Okay, go ahead, Kanchan. All the very best. Your first talk as a FIC, as the
As a governing
Yes,
council.
ma'am.
governing council member. Yeah.
Okay. Are my slides visible?
Yes,
Yes,
ma'am.
please go ahead, ma'am.
Okay. Thank you so much, Meena ma'am. So today we'll be talking about FIGO classification of uterine fibroid. So learning objective of this talk today will be the chronological development of fibroid classification, overview of FIGO classification of fibroid, 2018 refinement, some limitations and future prospects. As we all know, it's the most common benign tumor and only 30% are symptomatic. And symptoms ranges from abdominal uterine bleeding, heavy menstrual bleeding to infertility, recurrent pregnancy loss and bulk symptoms. So the classification of uterine fibroid has evolved from a simple anatomical description to a standardized system that guided surgical and medical management. And before 1990, we used to have traditional classification depending on the anatomical location, that is submucosal, intramural and subserosal. In 1993, the classification given by Wamsteker, which was adopted by European Surgeon of Gynecologic Endoscopy, they classified submucous fibroid, and it was further refined in 2005 by Lasmark, and that gave step W classification for submucous fibroid hysteroscopic resection for the surgeon. In 2018, the FIGO Munro et al. Gave the comprehensive classification system of the for the uterine leiomyoma, which was further revised in 2018. As we are talking about the classification of a fibroid, let us have a quick look of other classification like ESG classification for submucous myoma, which classifies type 0, type 1 and type 2 depending on it is determined by saline infusion sonography and hysteroscopy. And then there is SW classification for submucous myoma, which was introduced by Lasma to provide more granularity for submucous fibroid, accounting for size, topography, extension of the base and penetration. And as far as FIGO classification is concerned, it was developed with the goal to provide a standardized method for describing the relationship of given fibroid to endometrium, myometrium, and serosa, and to enhance the consistency in clinical management, to improve the communication among healthcare provider, and for the purpose of epidemiological and clinical research. It originated from FIGO's Committee on Menstrual Disorder and Related Health Impact, and it is a part of broader classification, PALM-COIN classification of AUB, and which can be applied to patients with AUB, infertility, recurrent pregnancy loss, and other symptoms arising out of fibroid. It was first published in 2011 and refined in 2018. So this FIGO classification, it maintains 3 level or hierarchy. The level 1 is binary, where we define it mere presence or absence of fibroid by AUBL. Then again in level 2, this AUBL is divided into AUBL-SM, that is mucosal, and other locations, that is AUBL-O. And in level 3, there is detailed mapping of the fibroid according to its location and myometrial involvement. So this International Federation of Gynecology and Obstetrics classification system, this identifies 9 specific types from 0 to 8 and a hybrid category, where submucosal group comprises type 0, 1 and 2, and other group comprises intramural type 3 and type 4, and subserosal other group type 5, 6 and 7, and 8 includes other fibroid at other side, that is broad ligament or at the cervix, and there is hybrid category where fibroid that involves both endometrial and serosa. So this is the FIGO classification of fibroid, where SM means encompasses 0, 1 and 2, where 1 is less than 50% intramural, 2 is more than 50% intramural, and 0 is pedunculated intracavitary. Then other is 3, 4, which is both are intramural, but 3 just touches the endometrium. It is 100% intramural but touches the endometrium. 5 is subserosal with more than 50% intramural. 6 is subserosal less than 50% intramural. 7 is subserosal pedunculated, and 8, as we discussed, it other site like cervix or parasitic. And then we have a hybrid variety where the two numbers are listed, that is separated by hyphen, and this, the number 1 refers to the endometrium part, and the first digit in the hyphen, and the second digit that refers to the subserosal part. The commonest is 2 to 5. This is the pictorial representation of the FIGO classification of fibroid. As we can see, 0 is pedunculated inside the endometrium, and 7 is subserosal pedunculated and subserosal pedunculated leiomyoma. And in the there is 1, 2, 3, 4, 5, 6, 2 to 5 which is touching both, which is involving both comprising of both subserosal part and subendometrial part. And now it was developed in 2011. In 2018, FIGO did some refinement in this classification to improve the clinical accuracy and standardized reporting. While the core 0 to 8 classification were retained, they made a minor revision. And what are those revisions? First, there was reclassification of type 3 fibroid. Now, type 3 fibroid are now formally categorized as submucous leiomyoma rather than intramural. And the type 3 fibroid, although 100% intramural, but it remains in contact with endometrium. And they advocated the use of hysteroscopy to distinguish type 3 fibroid from type 2 fibroid, to be done with the lowest possible intrauterine pressure to ensure clear visualization of the endometrial contact. And now they define the pedunculated fibroid, that is the pedunculated type 0, submucosal, and type 7 subserosal fibroid, where they define narrow stalk as a diameter having equal to or less than 10% of mean diameter of the fibroid. And they also advocated a standardized mapping and reporting of the imaging data set, which include that the imaging should mention total number of volume, total fibroid count, and they should locate mapping like describing the position as anterior, posterior, lateral, right or left, fundal or central, and its position in the vertical plane, that is upper half or lower half or both, and specific measurement of up to four of the largest fibroid in case of multiple fibroid or most clinically significant fibroids. And also they reinforced the use of dual number to describe hybrid fibroid, that is 2 to 5 or 3 to 6. Now the diagnostic modality which they used, the primary diagnostic modality was ultrasound, transvaginal ultrasound, for detecting and classifying fibroid based on the relationship to endometrial cavity and serosa. And MRE were recommended in case of complex fibroid or multiple fibroid for evaluating the numerous or large fibroids. Saline infusion sonography were advocated for detailed evaluation of submucosal component, that is 0, 1 and 2. And hysteroscopy were advocated to use for direct visualization to distinguish between type 3 and type 2 fibroid. And these refinement were done to for their better surgical and medical management, especially better medical surgical management, whether they should be managed with hysteroscopic, laparoscopic or abdominal technique. So these are few pictures, ultrasonographic pictures, which showing the different type of fibroid. In upper left corner, the ultrasound we can see there is FIGO type 0 and FIGO type 5 fibroid. In the lower part, we can see saline infusion sonography showing FIGO pedunculated, that is type 0 fibroid. And the right side, we can see in saline infusion sonography FIGO type 2, where it is encroaching into endometrium. The fibroid is encroaching into endometrium, but less than 50% is inside the endometrium. And now this USG is showing type 5 FIGO type 6 fibroid, subserosal type, where more than 50%, less than 50% is inside the myometrium. This is hysteroscopic picture of the FIGO type 0 fibroid, where we can see the beautiful pedunculated fibroid inside the endometrial cavity, and this is operated by me a few months back. And the right side showing picture of after hysteroscopic myomectomy by resectoscope. And this is the hysteroscopic view of FIGO type 1 and type 2 fibroid. In the left side, we can see there is this is the more than 50% is inside the endometrial cavity, and there is the angle between the endometrial surface and the myometrial surface and endometrial surface is more than 90% in case of FIGO type 1. On the right side, type 2, we can see the less than 50% is inside the endometrial cavity, and the angle between the surface of myometrium and the surface of the fibroid is more than 90%. So this is how hysteroscopy helps in diagnosis of type of FIGO fibroid, type 1 between type 0, type 1 and type 2. But yes, few studies and clinical and academic studies they have found some limitations in this 2018 revision also, like there is significant interobserver variability, and around the one major study they found that the agreement is made only in 14% of cases, and there is a type 3 fibroid controversy. Like the new revision has classified type 3 as a subset of submucosal fibroid rather than purely intramural, which has gave rise to surgical uncertainty, and also it needs saline infusion sonography or hysteroscopy under controlled pressure to see acute distortion of the cavity. And also there is challenge with the in case of large or multiple fibroid, because they are giving reporting of only purely anatomical reporting, which is not helping much in the management plan. And also there is certain missing data points, like they do not take account for the vascularity and proximity to the endometrium or serosa, which is essential for predicting the success of uterine artery embolization. So what are the future prospects? The recent literature has proposed further refinement of FIGO system for more surgical focused classification. For example, some mucosal differentiation. There should be detailed classification for hysteroscopic surgeon focusing on myometrium free margin. And also the intramural subclassification proposed to classify intramural type 4 into type 4A that disrupts the junctional zone, and type 4B that doesn't disrupt the junctional zone for the better prediction of impact on fertility. And also they have proposed for size-based categorization, while FIGO focuses on location. Recent study has incorporated size for clinical management, like small, less than 2 centimeter, medium 2 to 6 centimeter, large 6 to 20 centimeter, and giant more than 20 centimeter. These are my references. Thank you so much.
Thank you very much, Dr. Kanchan, for a comprehensive overview of the FIGO classification. I think that's a necessary background that all of us need to have when we're talking about fibroids. Are our chairpersons back? Can I request you to please introduce
I would like to compliment Kanchan. Kanchan, you have really done a good job. Okay.
Thank you so much, ma'am.
Yeah.
Thank you, ma'am.
Congratulations, Kanchan. Very nice.
Thank you, ma'am.
So, can we have the next CV, Dr. Archana Basirs? I think.
So maybe there's a network issue. We can formally introduce Dr. Archana Basir as a past chairperson of the FOGSI Imaging Science Committee. She's been vice president of FOGSI. She's also served several other organizations, including ISAR, and she's one of the FOGSI presidential candidates for the election this year.
Thank you, Pratik, for kind introduction. And may I be allowed to share my screen, please?
Please go ahead.
Is screen visible?
Yes, ma'am.
Yeah, so thank you very much, Team ICOG, for inviting me to deliver this talk. And let me congratulate the newly elected team of ICOG, Dr. Sheila Mane, Dr. Pratik Tambe, and all the ICOG Governing Council member. And my talk today is mapping of fibroids and imaging. Whenever there is a master class, there is going to be some overlap because we all are talking on the same subject. So why really we need mapping of fibroids is, Kanchan has set a stage very well with the FIGO classification. There will be a little bit of FIGO classification in my images as well. So why do we need new options? When we know that fibroid is one of the most common and well-known gynecological problem, we have read and dealt with it in our PG days, and the management was laparotomy, myomectomy, or hysterectomy. But now we are practicing in new era, and where we have other options as well, like medical management and which fibroids to operate and which not to operate. So, mapping of fibroid is a newer perspective in patient care. Why we need mapping? Non-surgical versus expectant versus operative management. There is an emergence of minimal excess surgery and resurgence of vaginal surgery. Patients' expectations and counselings are different. Duration of surgery, anesthesia, and OT scheduling all depends on what is the size of fibroid, what is the location of fibroid, and you have to decide about the operative access. If it's a huge fibroid, and what modality you will be using, and choices and availability of instruments is also very very important, and some budgetary consideration are to be taken into account, and discovery of lesion by a colleague shortly after surgery, that becomes quite embarrassing if you have missed the fibroid, it was not mapped properly by your ultrasonologist or by yourself if you are scanning. So scope of my talk would be fibroids, what is the extent of problem, and I'm going to be mainly focusing on diagnostic modalities and current advancement in mapping of fibroids. I'm not going to touch upon modalities of treatment because it is will be dealt by other team. So if you look at the symptoms of fibroid, uterine fibroids are the most common form of benign uterine tumors. They present with abnormal bleeding, pelvic masses, pelvic pain, infertility, and bulk symptoms and obstetric complications. Incidence, as we know, almost a third of women with leiomyoma will request treatment due to symptoms, and current management strategies mainly involve surgical intervention, and the choice of treatment is guided by patient's age and desire to preserve fertility to avoid hysterectomy. Now, fibroid location of fibroid, it can be inside the uterus, which is more common, or it can be extrauterine. We see FIGO staging in next slide, though you've already learned it. And extrauterine, it can be broad ligament fibroid, it can be parasitic leiomyoma, or it can be cervical leiomyoma. So fibroid in uterus, just look at this picture, which was there in the previous speaker's slide as well. These are the classification, FIGO classification of fibroid, like a submucous fibroid. There can be subserosal fibroid and type 2 to type 5 FIGO staging, then 5 subserosal, and then you have a pedunculated fibroid. So this is the FIGO classification of the fibroids. Now, diagnostic modalities. Let's focus on diagnostic modalities. Modalities, we have ultrasound, which you can do transabdominal ultrasound, you can do transvaginal ultrasound, it can be 2D ultrasound, 3D ultrasound, and with recent advances in uterine ultrasound, such as fibroid mapping tools are also available. We have AI also in the fibroid mapping, and so fibroids can be mapped, identified, and removed vastly, improves the patient outcome, and expands the abilities of the surgeon. So that's what is the role of mapping. And enhanced fibroid mapping tools can also identify information about the structure and makeup of individual fibroids, providing information that can be bolster preventive steps before and during surgery. MRI, yes, it can be used as a complementary diagnostic modality, though it is not important to do the MRI in each and every case of the fibroid. So let's look at the ultrasound features of fibroids. So pelvic sonography remains the imaging modality of choice for initial evaluation of myometrial pathologies, And the advent of vaginal sonography and color Doppler sonography have allowed for major refinement in detection and accurate diagnosis of common disorders affecting the uterus, especially myoma and adenomyosis. And fibroid mapping using ultrasound can also provide relevant information regarding the feature of individual fibroid, for example, their vascularity and echogenicity. The more vascularized a fibroid is, the more bleeding should be expected during surgery. And echogenicity can indicate the difficulty with which a fibroid can be removed. Real-time high-resolution structural imaginary images can be used in the diagnosis stage via non-invasive ultrasound techniques. In doing so, user can gain a deeper understanding of fibroids' type, variety, number, and location, and gather surgical data that will determine the best approaches before and during surgery. That is the purpose of mapping of fibroid. Let's get into a little bit of ultrasonographic anatomy. When we scan, this is a nice normal ultrasound of uterus where you can see the serosa, you can see myometrium, and you can see endometrium here. This is the outer myometrium, this is the endometrium, this is the endometrial thickness which we report always, and this is how it is structured. This is stratum functionalis, stratum basalis, and this is inner myometrial junctional zone, and this is the serosa. So this is a equal, anterior and posterior are equal, and this is a nice normal uterus on the ultrasonography picture. Now this is the myometrial layers. This is the inner junctional zone, this is the middle, and this is the outer. So that's where that's what comes in the when you do the FIGO classification, where the fibroids are located. So now what are the typical findings on ultrasound when you have a fibroid? Usually it shows well-defined, solid, hypoechoic, darker than surrounding tissue mass in the myometrium, often with posterior acoustic shadowing and a characteristic peripheral blood flow on color Doppler. They can vary in appearance. They can be isoechoic, heterogeneous, and location can be intramural, submucosal, and subserosal, and may have calcification, bright spots, and strong shadowing or cystic areas. Now, the common ultrasound characteristic: echogenicity, hypo, isoechoic, shape, well defined, texture, heterogeneous, mixed appearance is common, especially with degeneration. There will be acoustic shadowing, and if you see on the color Doppler, it shows the peripheral. So you look in these two pictures, the difference here, this is a fibroid which is a well-defined, well-circumscribed, what you can see is encapsulated thing. So this is the capsule, and this is the endometrium, and this is the fibroid. While you see in the another picture here, this is again a coarse echogenicity, it's a coarse myometrium, and that's a focal adenomyoma because there is no capsule around it, and this is not a well circumscribed, ill-defined capsule. And if you put the color, what you see in the fibroid, there is a peripheral supply of the blood, and while diffuse vascularity is seen in adenomyosis, that is the common pathology in the myometrium, which you have to differentiate fibroid from the adenomyosis. This is the FIGO type 0 fibroid. You can see here in the picture. This is type 0. It is a submucous fibroid, and this is a type 1 fibroid. Now let's move on to other pictures. So this is again, you see here the endometrium. This is a 3D picture, very well encapsulated fibroid. So this is, and then this is an intramural fibroid. Look here, this is the endometrium, this is the fibroid, and this is a clear picture. When you see the clips here, you can see that very nice circumscribed. So difference between adenomyosis and fibroid is, fibroid, the shape of the uterus become irregular, while in adenomyosis, the shape is retained, only the size increases and it becomes a little bulky. So when you see fibroid, may be irregular in the shape. So here again, this is what you see is a fibroid, which is a grade 5, FIGO grade 5 fibroid, where 50% is intramural and 50% is outside, and endometrium, it is not impinging on the endometrium. So this is the type 5, FIGO type 5 fibroid. And look here again, this is the 3D picture of the same fibroid. So this is again the FIGO type 5 fibroid you see here. And the similar thing which is seen on the laparoscopy versus ultrasound picture. This was the ultrasound picture, and what you see here is the laparoscopic picture of the same fibroid. So this is the FIGO 5 and FIGO 6 fibroid, where the fibroids are in the myometrium as well as extending into the serosa but not pressing on the endometrium. And this is subserous and intramural laparoscopy versus ultrasound again. Look at here uterus, and this is the fibroid here. What you see here is the uterus, fallopian tube, ovary, and this is a fibroid. A little bit of fibroid is inside the uterus, but rest is in the serosa. So it is very important, because once you have identified what is the staging of the fibroid, you know how much should be the extent of surgery and what counseling you need to do. This is a FIGO 7 fibroid, which is almost outside the uterus. So this is FIGO 7 fibroid. And then should you be doing CT scan in fibroids? So once you know how to do a scanning of the fibroid by ultrasound, I think CT is not needed. But fibroids are usually seen as soft tissue density lesion and may exhibit coarse peripheral or central calcification, and they may distort the usually smooth uterine contour, and enhancement pattern is variable. What's the role of MRI in fibroids? MRI is not generally required for diagnosis except for complex or problem solving cases. Suppose if you have a multiple fibroids, or if you have operated the fibroids has come back again, or if there are like a case which is a previous, you are expecting a lot of pelvic adhesions and there are fibroids, endometriosis, all combined together. You want to know that what is going to be the extent of your surgery, or there are adhesions. So I think MRI, as I say, is in the complex or problem solving cases where you are not only seeing circumscribed fibroid, and where simple myomectomy you can do and get away with it. So it is very, very important, and it is, however, more sensitive than ultrasound for detecting, localizing, and characterizing the fibroids. Size, location, and signal intensity should be noted. So just to summarize, fibroids are common finding on ultrasound. Fibroids are common presentation in OPD. And in the modern days, we are not ready to accept reporting just as a fibroid. I think as a clinician, as a gynecologist, we have to emphasize to our sonologist colleagues that we need to know what is the exact. I do not like the report multiple fibroids are seen. There's nothing like multiple. You can always count. Nowadays we have softwares available. You can even know the volume of the fibroid. So each and every fibroid has to be reported, because everybody is good in reporting the large fibroid. Large fibroid will get reported. What about the small fibroid which is left? Especially, when you are doing a surgery, you know that you are going to be removing the larger one, but if you leave the smaller one, that is going to grow back in some time. So if you are operating the women for fertility issues, and then she's again at the square one. So it is important that each and every fibroid reported, their location is reported, and a mapping is done properly. So we have to do a correct management and counseling, and we have a very good article on this in our book on how to map the fibroids. And this we wrote for the beginners only, where they can go, and it is in a question answer pattern. And this is me with the largest fibroid which I removed, which was, you can see here, it was about 10 kg and 360 grams. I think we are living in the modern time, and we should not let our women go into that stage. Whenever there is a fibroid, right diagnosis, correct staging, mapping, and a right treatment has to be offered, so that women don't suffer that much. And with this, I invite you all to this all vice president conference at Indore, 8th, 9th, and 10th May, and we'll discuss and talk more about fibroids in that if you wish. So thank you very much. Better is possible. It does not take genius, it takes diligence, and it takes moral clarity, it takes ingenuity, and above all, it takes a willingness to try to do more. And thank you very much. And I am contesting for FOGSI President election in 2026. So I need your blessings and support. And I'm going to be there with you, for you, and by your side, as every member matters. Thank you so much.
Thank you, Dr. Archana Basid. I don't think there could have been a better speaker on this topic of fibroid mapping, giving your background and the fact that you hold the Guinness record for the largest fibroid removed. I think it was a perfect choice and a perfect fit. Fantastic talk, excellent videos as well as still images. I would request Dr. Tarini to please introduce the next speaker, Dr. Sujata Mishra. Can we
Thank you,
have her CV
Pratik.
on
Thank you.
screen, please?
Thank you, Chairperson.
Share.
Dr. Tarini, please unmute. I have sent you a request.
Okay. So, first of all, good evening, and thank you so much for the chairperson and secretary for giving me the opportunity. And I'm just introducing Professor Dr. Sujata Mishra. She is a director, Postgraduate Institute of Medical Sciences Research, Bhubaneswar, Odisha. We know very well. She's a very wonderful person, friend of the friend, and she have been the vice president FOGSI in 2015, and she has got very research paper, principal investigator, and co-investigator, many awards to her credits, and publication to her credits. So over to Dr. Sujata for the medical option treatment for the fibroids.
Are my slides visible?
Yes, ma'am. Visible. You can go full screen, please.
I'm just going 1 second. I was not too sure because I didn't share. Okay,
Yes.
fine. Okay, so what's the time here? So good evening, everybody. Thank you, all friends over here. Thank you, Dr. Sheila, Dr. Meena, Dr. Pratik, Dr. Tarani, Dr. Archana. The names would be endless. It would just take up time. So we go quickly on to medical management of now fibroids. Now, one disclaimer over here. Although I say medical management, please do not think that this is the ultimate and you see a fibroid means you can treat it with drugs, because towards the end we'll realize how we really don't stand too good in that place. Now, by far and large, most of the leiomyomas are asymptomatic. Before you decide whether you want to give a medical management, you want to treat them, see if it is first and foremost required. Those who are clinical, they may be having bleeding.
Sorry to interrupt, ma'am.
Yeah.
You're not full screen, ma'am.
I am full screen.
Oh, okay. And this end, we can't see the full screen,
Or shall I
unfortunately.
stop sharing and share again?
Yes.
Please
Okay.
try once.
Let me
Sometimes
do
it
it.
happens with older versions of Office.
Yeah, this is an old version. देखो इसको मैं कर रही हूँ, ठीक है ना? Share करूँ पहले? First I'll share it, right? Yeah. So I shared it. Is it okay?
Yeah, perfect. Ma'am.
Yes.
Please go
Oh,
ahead.
thank you so much, Pratik. Thank you so much. Okay, so the majority of them are asymptomatic. Those which are symptomatic, there's an issue with bleeding or anemia or bulk effect or reproductive issues. So we need to individualize based on symptomatology, size, location, age, whether she wants to preserve fertility, and if not fertility desirous, whether she wants to preserve the uterus, because people have their own ideas, then the availability of therapy and the experience of the clinicians. So, why can't I go to the next slide?
Ma'am, click on the slide,
Just
ma'am.
click on the slide
Yeah, I
and
can't.
click again.
Okay,
Yeah.
why is it like this? Okay, anyway. So now the key rationales for medical management is either you want to control the bleeding or the pain, or you want to decrease the tumor volume for some fancy of yours for the surgical expertise. If you boil down to these other three basic things. For symptom control, we've got LNG-IUS, tranexamic acid, the GnRH agonists. We can shrink the fibroids temporarily for surgery. In order to preserve fertility, we may like to give. So the bottom line out here is medical treatments are often temporary. They do not provide long-term benefits or cure, and the symptom may return upon cessation. However, they have a very important role to play in that intermittent period. Usually we do it in order to avoid surgery if we can. It's not that if you give a drug that 5 centimeters fibroid is just going to disappear. It won't. And period, and it's only 3-4 centimeters after menopause, it's going to shrink by itself or as a pre-operative tool. Now, if you look at the So, is there any network issue? LNGIUS oral progesterone receptor modulators, we will come to. No. You can't see the unstable. I think there is a network issue, Pratik.
Yes, ma'am. We'll just wait for her to rejoin.
We can't hear you. That
Network must have been unstable. We'll just
network
wait for 2
unstable.
minutes. In the meantime, I would request the audience. I see the number is nearly 250, which is significantly larger than yesterday, and it is a very heartening point to note that we have such excellent attendance for both our inaugural programs. If you have any questions, I would request you to put them in the chat box, and after the speaker is over, we'll have a brief Q&A session before we go to the next session.
Can somebody call Sujata to see Ritu?
Ma'am
What
is
is
connected.
the
Yeah, I'll
problem?
call, madam. I'll call.
Madam has joined. Sujata ma'am has joined.
मला पण थोडा द्या मावशी.
Hello.
Okay, ma'am. The second or the third slide. Okay. She's joining back, madam. She's joining.
ಮೇಡಮ್ ಎಷ್ಟೊತ್ತಿಗೆ ಸಿಗ್ತೀರಂದ್ರೆ ಅವ್ರಿಗೆ ರಜೆ ಹಾಕ್ಬಿಟ್ಟೆ ಅದಕ್ಕೆ.
See you as yet, madam. You started your share. Okay, okay. Okay, fine. Yeah. Yeah, we can see your slides, madam. Okay. She's joined, madam.
Maybe you can just keep your video off, ma'am, and continue speaking. Sometimes that helps.
So I have kept the video off. Am I audible, Pratik?
Yes, ma'am. We can see you and hear you. Go ahead.
Yes, okay. Yes. Fine, fine. Let me go ahead. Sorry for that interruption. So when we talk of tranexamic acid, it is said, we know that it's available at 500 milligram tablets. It is said to cause an average reduction of 89 ml per cycle in the menstrual bleeding. But what it does not do is it does not affect the size of the fibroids, and there can be adverse effects. So if at all we want to give non-hormonal tranexamic acid, there can be a reduction. It can be given orally. We rarely give it intravenously, even though we can give it, but it is just for symptomatic use. Then we come to the next slide, which is progestins. They can be local or they can be synthetic. So when local, we will talk a little about the LNG-IUS first, and then I will go on to the other progesterone and progestogens. When we talk about the LNG-IUS, we all know it's a synthetic derivative of the hormone progesterone, which delivers some amount of levonorgestrel, which is the derivative. Now, although it was advocated for use in 2009, a prospective comparative study investigated the effect of LNG-IUs in women with fibroid-related heavy menstrual bleeding. Within 1 month of insertion, the pictorial blood loss assessment chart score fell by 86.8%.
I'm sorry for this crowded slide. I needed all the numbers. And within 48 months of use, the control of the blood loss fell down to 99.5%. So the mean uterine volume also was significantly reduced. Now, this is very funny. You must listen to this. The mean uterine volume was significantly reduced, but there was no statistical significance in the study, a reduction in the fibroid volume. The p-value was not significant. However, this is a good modality that we can try the insertion of the LNG-IUS. Patients should be informed that there's a risk of device expulsion, which has been associated with uterine fibroids larger than 3 centimeter. Then we will talk something about our progesterone and progestogens. Both natural progesterone and synthetic progestogens can cause endometrial atrophy. The progestins stabilize the endometrial fragility, inhibit endometrial growth, inhibit angiogenesis, and decrease the blood loss. They stimulate the conversion of estradiol into less active estrone and prevent ovulation and ovarian steroidogenesis, thus interrupting the production of estrogen receptors and estrogen-dependent stimulation of the endometrium. Now, when I talk of the progestogens, let me just make a distinction for the more junior people who are in here, that when we say progesterone, we only mean the natural micronized progesterone molecules. When we talk of progestogens, we basically refer to the synthetic ones. And what are the ones which we normally use? We usually use oral medroxyprogesterone acetate, MPA, norethisterone, and amongst the natural ones are the micronized progesterone. It is said that norethisterone as compared to MPA is a better antistyptic. Just some clinical points. And further, it decreases the volume of uterine bleeding as determined by visual bleeding score by almost 50% over 6 months of treatment. A systematic review published in the Cochrane Library compared progestogens with the LNG-IUS system. The only thing of importance that they reported was there was more of a spotting with use of LNG-IUS as compared to those who took norethisterone acetate tablets. All of us, those who have given LNG-IUS and norethisterone, must have witnessed this, because in the first few months of insertion of LNG-IUS, there is some spotting. All it needs is some reassurance to the patient. Moreover, it is cost effective, the norethisterone that is, and severe adverse effects are limited. However, it is important to keep in mind that oral progestins again do not reduce the fibroid volume. Next, we'll talk a little about the oral contraceptive drugs. Now, we all know it's got estrogen and progesterone. In one point of time, we say that the fibroid is estrogen dependent. And then we say, look, you can treat it with COCs. So where do we stand? Again, if you use these values which I show you, or numbers which I show you, are all from various systematic surveys and study. And the latest reference is the one, I think it is about, it was in September 2025, all the data which I'm sharing now. So it says that, again, it has the capacity to decrease the blood loss by about 53.5% if you use COCs. There was no evidence in systematic analysis to suggest that the COCs promote the growth of uterine fibroid, although they do not decrease. This is to be noted, that they do not decrease the fibroid volume. What is important is, in this case, is to think about the age of the patient. The available data indicates the COCs may be a treatment option for women experiencing heavy menstrual bleeding. However, older women, they remain a subject of debate. It's advisable to consider formulations with lower estrogen doses and carefully selected progestogens to minimize the risk of thrombotic or cardiovascular events. All said and done, to summarize, COCs cannot be considered a universal treatment strategy for uterine fibroids, particularly in older patients. One line about people who are on HRT, whether or not you would like to give them this. Well, uterine fibroids might be influenced by HRT because she has a fibroid, asymptomatic. You put her on HRT, will or will not there be an influence is what people may ask you. Now, it is not an absolute contraindication, but it is definitely also not the first choice. But if you're giving her, you got to monitor her and discontinue if the fibroids appear to increase in size in regular monitoring. About gonadotropin hormone releasing analogs, we know that we've got both agonists and antagonists. So first we will talk a little about the agonists and then we will go to the antagonists. If you give these agonists, fibroids may be expected to shrink by up to 50% of their initial volume within 3 months of therapy. So it can be used as a preoperative adjunct with a duration of treatment limited to 3 to 6 months to shrink the fibroids, reduce the anemia related to uterine bleeding, and reduce the surgical blood loss. It can be given for patients undergoing laparoscopic myomectomy. I mean, we've got people, experts talking about that. It could be a pre-treatment to reduce the blood loss and the need for more blood transfusions. However, its use prior to hysteroscopic myomectomy, as reported in this study, is not well elaborated nor studied. Short-term GnRH agonists with or without add-back therapy can also be used in perimenopausal patients to facilitate the transition to menopause. Now, what is the problem with the long-time use? You need an add-back therapy. Very simple. Whether you want to give them tibolone, let me not read the whole of this slide. It just means if you want to give this agonists for a long time, you've got to look for some add-back therapy. It could be tibolone, it could be raloxifene, it could be estriol. Ipriflavin is there in the, in various literatures, but I cannot say I have too much of an experience with that. So only disadvantages is you cannot use it for a very long time. Now, if you come to antagonists, now while agonists cause that flare effect and they take about 1 to 2 because they cause continuous stimulation and they cause a flare effect and then there is endometrial atrophy. But with antagonists, they bind reversibly to GnRH receptors without stimulating them, which was not there in the case of agonists. So they do not produce a flare effect. They cause medical castration levels are reached within 24 to 72 hours following the drug administration. Recent randomized controlled trials indicate that these antagonists can be used for reducing menstrual bleeding in patients with fibroids with decreased uterine volume and improvement in the quality of life. Now, while add-back therapy was shown to reduce vasomotor symptoms and BMD loss, uterine volume changes were more pronounced in therapies without add-back. While it is said that while treatment with agonists require add-back more often if you give for a longer time, those with the antagonist, you may not need to give them. So what are the 3 drugs? In 3 slides, I'll discuss the 3 drugs. Oh, my time is over. So, okay, one is Elagolix. We all know about it. It is there since 2018 and it was propagated actually for endometriosis, but now they say you can give it. The next is Linzagolix. We haven't heard much about it except for the Primrose trial. More studies need to come in. And the third is Relugolix and its combination therapy with relugolix, estradiol, and norethindrone acetate. Symptomatic relief was noted in all of them with some, decrease in the pain and the size, but we need more literature before we can actually advocate them for fibroids. Now, this is the last slide and the last word. Now, SPRM, a lot of you must have written a lot about ulipristol, 5 milligram, give it, this is the miracle molecule. But right now, Canada has said, no, you cannot give. US FDA has said, no, you cannot give. So I looked out to see what our Drug Controller General of India has said. Well, they've said, yes, it is associated, one in several cases, with severe liver toxicity. So one has to rationalize before giving ulipristol for a longer time, and you can only give it for cases where surgery is not indicated at present or you want to buy time for a short while. So this, friends, brings me to the last slide, wherein you see tranexam. I said all the drugs are out here. SPRM have the problem of liver injury. The others have some major concern of hormonal this thing. So the main thing is medical manage is to tide over the situation for a short time and to control the bleeding issues. Thank you so much for a very patient listening, and sorry for the disturbance in the network.
Thank you, Dr. Sujata Mishra, ma'am. Fantastic deliberations, and despite the network issues you soldiered on, I would request our chairpersons, Dr. Meena Samant, Dr. Tarini Kaneja, and Dr. Yashodhara Gaur to please conduct the Q&A session. There are 4 or 5 relevant questions. We have about 10 minutes before the next session begins.
Dr. Yashodhara has joined.
She is joined. I think she's on her phone.
Yes, on the phone. Yeah. Welcome, Dr. Yashodhara.
Dr. Kusum Singhal wants to know the role of
problem is
mifepristone.
existing.
Dr. Sujata, it's for you, I think.
Yes.
Role of mifepristone.
Yeah, tell me.
This masterclass has covered all the topics so nicely by the speakers, Dr. Kanchan Prasad, Dr. Ajna.
So, Meena, can I come in about mifepristone?
Yeah.
Hello?
Question that Dr. Satilal wants to know.
Yes. See, a word about mifepristone. Yes, it is an antagonist. Yes, it is put into use, but it does not actually reduce the size very appreciably. This is what the literature has said. One can use it. It is advocated for use. It acts as an antagonist, which is why I did not touch on DMPA, androgens, and mifepristone.
Okay, another one, Dr. Sushila Kunte wants to know, does degeneration in an existing fibroid an indication for surgery, or role of LDH blood test in fibroid?
So I think this is a surgery question. Maybe it is
I
more
think we can
relevant
take
after
it in
the next session.
next session.
Dr. Swati Singhal has a more interesting question. Let's take that. It's just above.
What is the question?
Okay. A 36-year-old primary infertility with big subserous anterior wall fibroid about 6 centimeters and submucous fibroid polyp with menorrhagia with male factor infertility desiring. Yes, ma'am.
Now, in this particular case, if the chairperson and secretary would give me thoda sa extra time, I would share an experience of mine. Now, if this uterine endometrial one, also a polyp, it needs to be removed. Number one.
वीडियो करके बात करो.
Sorry, ये बहुत गड़बड़ कर रहा है. Okay.
वीडियो ऑफ करके बात.
अभी ठीक है? Is it okay?
Yes.
So if there is a polyp or an endometrial fibroid impinging into the cavity, it can disturb the nidus of the embryo. So one has to remove it. Number one. Now, having said that, when there's a small fibroid, maybe myometrium or subserous, if she gets pregnant, she should be allowed to continue. We will not think of any operative therapy at this point of time. And I'll tell you why I'm telling you these things. And if at all she has been trying, and this presence of a moderate to small size fibroid is she thinks is the culprit, then it's not the culprit. Only if the cavity is distorted or if it's a big fibroid, then we need to remove it. I have experienced 2 experiences. One was this lady came to me at 4 months of pregnancy, 4 months, right? 16 weeks with a mass, right up to the xiphisternum. That the patient was not mine. When you're young and you get referrals from nursing home, and she could barely breathe, nothing could be done. And they said, madam, there's a big myoma. At that point of time, we never used to touch myoma. And this is the first and last case of antenatal myomectomy that I have done. You have to believe this. Even I did not know what I was getting into. But she was in so much of pain, we had to do something. So I just took out that myoma. It was subserous. We had seen it in the ultrasound, and luckily nothing happened. And she went up till 36 weeks, and I had the cushy of doing a cesarean for her. This is one thing. Then just 1 year back, we looked at a lady with endometriosis, with multiple fibroids, but the cavity was all right. Okay, so she did conceive. None of the fibers are beyond 3/4 centimeters. She did conceive, and again, when she delivered, we did a cesarean myomectomy. So it's both ways. But if there is an inside the cavity, there's a polyp which is causing issues, a fibroid polyp, it definitely has to be removed. I would not say the same about a 4-5 centimeter fibroid, which is serosal. This is my view. Thank you.
Thank you, ma'am. Thank you for those interesting
Dr.
insights.
Sujata,
Yeah.
Dr. Pratik, could I take one more question of Dr. Purnima?
Yeah, I wanted to take that because Purnima Ranka, if it's the same person, she is actually my batchmate. Hi, Purnima. Purnima, nice to reconnect with you. Her question is a postmenopausal 53-year-old lady, one episode of bleeding, Figo 5 fibroid, 2 years ago was 3 centimeters, now it's grown to 5 centimeters. Definitely needs investigation
And
and
surgical management.
needs to be
The
treated.
size has increased now.
Yes, surgical.
And you can take that last one, Dr. Sushila Kunte. Menopausal women, 5 centimeter asymptomatic fibroid. What should be done? Any of the speakers wants to take that? Dr. Kanchan, you want to speak about it? I think she's not there. So I think if it's asymptomatic, then surveillance is fine, but always beware that fibroids can undergo malignant transformation for leiomyosarcoma, and our testing, whatever we do, surveillance sometimes may be inadequate to pick that up.
LDH, somebody is mentioned, yeah. LDH,
Yeah.
somebody is mentioned.
LDH.
Correct.
Dr. Pratik, good afternoon.
Good afternoon, madam.
Dr. S.P. Jaiswal.
Yes, ma'am.
Can I share my experience of antenatal myomectomy?
Quickly, ma'am, 2 minutes because we have to go to the next step.
Dr. Kalyan wants to, be the co-host, please.
I
Somebody.
have
He's already co-host.
Okay.
I have series of 6 cases of antenatal myomectomy, and it is published also.
Thank you, ma'am. Please share the reference with us. We would like to share it with all our fellows.
Definitely.
And we'll highlight this in one of the future programs as well. Thank you for sharing that with us.
Thank you so much to our chairpersons and our speakers for that excellent deliberations that we had and a nice discussion. So moving on to the session 2,
Before we do that, Dr. Kalyan is the current president of IMG and he's joined in a little late. Can we have a few words of encouragement from him and then go on to the
I
next
would
session?
suggest if he has time, he can be there for the
Yes, ma'am. I will be
next
there for
sharing.
next trip. Yeah, we have some
Next
webinar.
sharing, sir.
Good evening, and this is a really wonderful talk by all experts about the medical management of fibroids. Asymptomatic fibroids less than 5 centimeter need not be tackled. As Dr. Pratik sir has already said, we need to evaluate these fibroids properly. At least 1 year surveillance is must. Though the incidence of leiomyosarcoma is very less, those fibroids which are growing with a large of increase in size by more than 3 to 4 centimeter in 6 months needs a special attention. A serum LDH level MRI is going to be helpful to rule out leiomyosarcoma. Otherwise, it's just medical management is there only for controlling the bleeding, post-management till the surgery or fitness is getting for the patient. Thank you, sir, for giving me this opportunity. I'll
Thank
be
you,
there
Dr.
for next
Kalyan, for
30 minutes.
gracing the occasion. Lovely to have you with us and wish to see your active participation in ICOG activities in the
Yes,
future.
sir. Thank you, sir.
Sir, we have Dr. Sarita Bhalirao ma'am also, who's there with us. She was stuck up in the OT.
Yeah,
Sarita
I think
madam.
she was in the vehicle when I saw her briefly. I don't know if she has network.
Sarita Bhalirao ma'am.
Okay.
No, I think she's unable to
So
join us.
we'll
We'll have her
continue
as
and
and when
move
she
to the
does.
session number 2, sir.
Yeah.
Yeah.
Yes.
So for the session 2, I invite the dynamic chairpersons, Dr. Kiran Pandey, who has been the chairperson of FOGSI Medical Education Committee. Nilima, can I have the CVs over here, please? Yeah. And she was the former professor and head of department, OBGYN, GSVM Medical College, Kanpur, and has a lot of awards with her and a peer reviewer of Indian Journal of Obstetrics and Gynecology. Welcome to you, Dr. Kiran Pandey. We have also Dr. Rajshri Katke, who is the professor and head of unit OBGYN, former head of department, Grand Convent Medical College, ex-superintendent of Kama and Elbis Hospitals, Mumbai, and also has been the Mumbai Achiever Awards recipient. So welcome to you, Dr. Rajshri.
Thank you.
Dr. Mahesh Koregol, who is the Senior IVF Specialist, and he is the National Strategy Director, Nova IVF Fertility, and also the President-elect Bangalore OBGYN Society. So welcome to you, Dr. Mahesh Koregol. So I hand over the mic now to our chairpersons, Dr. Kiran Pandey, to introduce the first speaker, Dr. S. Krishnakumar.
So before we do that, I'd like to place on record my gratitude to the chairpersons of the first session, Dr. Meena Samant, Dr. Arni Taneja, and Dr. Yashodhara Gaur, and of course the speakers for doing a fantastic job. Dr. Rajeshri, would you like to introduce?
Dr. Kiran Pandey?
Dr. Kiran Pandey.
Kiran Pandey.
Yeah.
So if I can introduce Dr. Krishna Kumar, sir and I have worked together for almost 17 years. He's a past president of IIG and he's a legend in the field of hysteroscopy. Unfortunately, he's away at a physical workshop in Indore, so he has been kind and gracious enough to record his presentation and he sent it over to us yesterday, requesting the backend team to please play it for us. His talk is going to be on hysteroscopic myomectomy along with a variety of videos and key practice points for all of us.
Yes, sir. Thank you, Dr. Pratik, for taking the work. But actually, it was not being, I was not being allowed to unmute. So that was,
please go. Over to you.
Okay.
Shreya, can you do the needful, please?
Krishna Kumar for a wonderful, he is a wonderful surgeon. We all know about it. Let's hear from him without wasting time. Dr. Krishna Kumar is here now.
I'm happy to be here in this FOGSI ICOG Masterclass on fibroids. And the topic given to me is safe hysteroscopic myomectomy. Well, amongst all the complications which a fibroid is known to cause, heavy bleeding, abnormal bleeding, infertility, recurrent pregnancy loss, bulk-related symptom, you will agree that submucous myoma is implicated in all these symptoms. Hence, treatment of the submucous fibroid is always mandatory. And as per the good quality of evidence, submucosal fibroids are to be managed by hysteroscopy, but there has been a cutoff limit of less than 5 centimeters. For the obvious reason is any surgery inside the uterus has to be finished in a specific time of maximum 30 to 40 minutes. And in patients who are definitely trying for fertility, submucosal fibroid should be removed in order to improve conception and pregnancy. That's again a grade A evidence. And we all know that preoperative assessment is very important. Somebody has already spoken to you all about the imaging requirement. Today, a good 3D sonography is definitely mandatory. But when you are dealing with office hysteroscopy, occasionally we would say that office hysteroscopy helps in figuring out exact location of the fibroid so that one can counsel the patient whether it's more type 2 or type 3 and what the size is, whether it will require 2 sitting. So I sometimes definitely do an office hysteroscopy when the sonography is sometimes inconclusive in telling me exactly the size or the location. Well, MRI is very rarely required in general, only when the fibroid is more than 4 or the uterus volume is large. Well, the classification, the routine classification, which we all are known about, Wormstaker or ESG 0, 1, 2, 3, depending on the location of the fibroid and its relation to the endometrial cavity. But that really doesn't solve the problem many a time because submucosal fibroid could be in different locations, and this Lasmar classification is something which takes into account not only the presence inside the endometrial cavity, but its extent into the musculature, the lateral extension, and its location in the lateral wall definitely. And there is a scoring system which gives, as per this, I wouldn't go into the detail, but Lasmar classification tells us that if the total score is less than 4, the complexity of the surgery is easy. The surgical treatment can be done by somebody who's a beginner or a new, but once the score increases up to 6, the hysteroscopic myomectomy is more difficult, and there are suggestions to give or reduce the size by giving GnRH agonist or to do it in a 2-stage procedure. And above 7, it is always recommended that it should not be done hysteroscopy, and one should maybe straight away go on with laparoscopy. Well, to understand the simple, when you put in an hysteroscope, its relation to the exactly to call is a type O, 1 or 2. If 100% of it is within the cavity and nothing is in the myometrium, that means it's a pedunculated fibroid. As you can see, in a type 1, one can see that 50% within the cavity, so the angle between the adjoining endometrium and the fibroid is less than 90 degrees, whereas if it's a type 2 fibroid, the angle is greater than 90 degrees. So this will tell you, yes, after putting in an hysteroscopy, you can still decide whether to go ahead with a large submucous fibroid of 4 centimeter, but type 2, which will definitely obviously take more time. And because safety is very, very important in any hysteroscopic surgery, I will tell you the reason why. Well, traditionally, we have been all doing slicing technique in hysteroscopic myomectomy. So it was a resection of submucous myoma, whereas in open or laparoscopy, we never resect the myoma, we enucleate it. And then the HTRS or the hysteroscopic tissue retrieval system has come, which is also for the morcellation of the fibroid. But the new concept is you have to enucleate like you do in laparoscopy or open, which preserves the pseudocapsule for obvious advantage because the damage to the endometrium. But one must agree that hysteroscopic myomectomy is the most difficult and complex surgery among all hysteroscopic procedures. Well, one can see how the slicing works. The loop gets dug into the substance of the fibroid, but we would recommend today the bipolar resectoscope and not the monopolar. You can see a fibroid which is in the anterior wall, the 4 millimeter depth of the loop of a 26 French resectoscope, how it takes out a bigger chunk, and one has to slice this very, very gradually as you go deeper. When you all have to know when to stop it, when we all see the mucosa, the muscularis layer, circular muscular layer. But you will agree that hysteroscopic myomectomy is not for a beginner to do. Well, the end point, you can see the white fibroid which is still there, whereas in the upper part you can see that you have reached the capsule there. But damage to the adjoining endometrium is something is always a little worry because you will tend to take out some amount of the normal endometrium when you're doing the slicing technique. Well, as you can see that initially the slices are a little deep, but as you go, you have to make it a little smaller. But what about multiple fibroid? Yes, these are fibroid which are almost on opposite surface, one in the anterior, one in the posterior. Not only will they need a little more time, thereby necessitating careful monitoring of the fluid overload, but chances of adhesion formation has been found to be more. So there was initially a theory that one shouldn't resect opposing wall myoma when the hysteroscopic myomectomy came initially, but then for obvious reason, for patient comfort, we all tend to do it in one sitting. Well, you have to counsel the patient what are the disadvantages of doing fibroid which are in opposing wall. The adhesion is the most commonest, and you can see how the slicing is done. You pass the current just before touching the fibroid and dig deep into it, then you may get a 6 or 5 millimeter thick of the fibroid slices, and you can see that the white structure is still the fibroid, and just beneath it you will start appreciating the smooth myometrial fibers. Well, definitely this was the only way we all were doing for almost 2 decades, till the time other technological advances brought us more options for the same. Now you can obviously see that as we are going deep into the myoma bed, we are having the thinner slices so that you don't damage too much of the myometrium. You can appreciate here the normal circular myometrium. So as you go on deeper, you have to be a little more slow. But don't worry about these bubbles which form in the bipolar surgery. They are not going to cause gas embolism. These are bubbles which are tissue generated, and they have to be just tackled by going close to it, start the suction, and they will be all absorbed. And after the posterior, you see that the anterior fibroid is being sliced. This is again a typically type O. The posterior was about type 1, whereas this is more of a type O. which is much more simpler. We can cut the base at times and leave it if we're exceeding time. And one has to, without any doubt, keep a watch on the fluid overload. The resectoscopic difficulty has always been the chips which keep floating inside the cavity obstruct your view. So as a beginner, even I found it difficult to work within the cavity, but repeated insertion and removal of the resectoscope causes more problem because the time taken is more. There is more bleeding inside, there is more loss of vision, and that more chances of gas embolism. And then definitely there is this problem where you have to try to do it in one insertion and take out. So that as per experience goes on, today I may be able to take a 4 or 5 centimeter fibroid in one single insertion and work within those debris, floating debris. The technique to work at incomplete resection is sometimes possible. Yes, said. If the fluid overload is more, or if you think that you cannot continue for obvious reason to prevent complication, you may stop it. But if you inadvertently do a wrong step, you may perforate, but that should not happen in modern hysteroscopy. If you're well-trained, perforation should not occur with the resectoscope because it can be extremely damaging to the adjoining structure, especially to the bowels. But that is where the complication, apart from the fluid overload, which is so very common in hysteroscopic myomectomy, as you can see in this slide, or rather video, where an surgery done incompletely in the first, but when we went in for the second time, there were already adhesions. So the trauma to the adjoining endometrium, bleeding and adhesions. As per this particular article, multiple myoma resection almost causes 45% of the intrauterine adhesion, and a single myoma resection also can lead to 31%, which is significant when you're considering the reproductive age group. Then, of course, the last decade or so, this particular device, which is also was called a modulator, but later on changed the name to HTRS, you can see how it works. It has a moving blade, and along with the cutting or the chipping the fibroid, it sucks the fibroid pieces into the system and it gets collected in the adjoining receptacle, which you can collect everything. And that is where the advantage of this method was you have no loss of vision. It is faster because the chips are continuously being absorbed, and the fluid overload chances may be less because if you finish a surgery faster, the problem of fluid overload is definitely minimized. But the main disadvantage is if at all there is bleeding, you are stuck up with because there is no energy in this particular device. But it is recommended that patients who are for reproduction, maybe this is a better way to do to prevent the damage to the endometrium, which is one of the commonest complications of hysteroscopic myomectomy, and obvious reason we do not want the endometrium to be damaged. Here you can see this is a real-time video where the blood is there, but still if you can locate the fibroid and continue the motor, you are absolutely fast and quick enough, and the fibroid within almost 5 minutes, it is complete. You can see the base of the fibroid and you can appreciate that the damage to the adjacent endometrium is very, very minimal. But obviously the other disadvantages, they are all expensive because it's a disposable blade. Supposedly the basic investment in the machinery is costly, but today we cannot talk about the cost when we are considering the advantages. But which is better? The published data is still limited. Those who are doing good resectoscopy feel that resectoscopy I can do better, so why should I switch over? But it's a lower operative time at a higher cost, and it's not a good one for type 2 fibroid or very hard fibroid, where obvious reason it is not going to cut it as fast as what you see all types of fibroid. But it is good for type O and type 1, and though the final judgment is not there, today by the time one can decide which is better, the concept of myomectomy has changed, and preserving the pseudocapsule has been shown to be very, very important because they contain all the neuropeptides and the blood vessel, especially when you're dealing in patient who are for reproduction. And for obviously, if the patient is for just menorrhagia, damaging the endometrium doesn't make a difference. Well, you have to know how to go into the plane like we do in open or laparoscopy between the fibroid and the capsule. And to work with those smaller, thinner scissors of 2 millimeter and 3 millimeter is definitely a little more challenging. So we started with the smaller fibroid. As you can see here, we have just cut the endometrium around the fibroid, which is a type 1. And once you start pulling it down with the same blade of this 2 millimeter scissor, you can appreciate that you are entering into the pseudocapsule, and see that you can just pull it, drag it down, and the fibroid is now becoming almost type 2. And you will appreciate that the pseudocapsule is so well maintained and there is no damage. So definitely the chances of adhesions are going to be very, very less. So the chances of bleeding in a fibroid is almost, though there, but it is not as significant as one fears in a laparoscopic myomectomy, when you can see because of the pressure of the fluid, the smaller vessels do get compressed and the body takes care of the bleeding. Here you can appreciate that we have almost reached the capsule, and this, though smaller fibroid of about 1.5 centimeter, we have dislodged it from the bed and totally removed it. Sorry. Now, this is a enucleation is the way forward, is one feels. That should be the way we should be going ahead. So this is a fibroid where you can see both in the anterior wall and posterior wall, these HTRS system have a little advantages over the conventional sheet, where a 3 millimeter or a 4 millimeter sheet scissors can be passed on, and you can appreciate the cutting of this scissors is much faster and much better. So you need to cut the endometrium around it, open the blade in between and try to cut those fibers and just push the fibroid into the cavity. So this is again about a 1.5–2 centimeter fibroid, and you can see how beautifully you can, just dislodge it. And you need to train yourself and then be sure that you can remove it completely. So once you have tackled this, and this fibroid, which is almost at the fundus and the anterior wall, but obviously if a fibroid is type 1 or type 2, if you're going to do a resection, you have to dig the endometrium, go deep into the myometrium, and obviously the damage is going to be much more than what you're seeing. So maybe this is a better way of doing, but you need a 3 millimeter scissor for faster surgery, not the 2 millimeter scissors which we conventionally use. Maybe a little more clumsy, the instrument can break, and since you have only one hand inside the uterine cavity, obviously the difficulty is going to be much more seen than a 3 millimeter scissor. But here you are seeing that though we are cutting the endometrium, there is no thermal damage, and after the enucleation, the endometrium is going to come back because of the collapse in the cavity, and there is no chance of, no fear of rather adhesion formation. You can see how beautifully you can enucleate the fibroid and bring it down totally into the cavity, and that's how the fibroid is completed. Now there are various ways of removing these fibroid which are totally enucleated and getting it out. I'll just show you the way, but this is how the fibroid, multiple fibroid in this patient, with this is the largest of the fibroid, about 2 centimeter, can be dislodged and put it in the cavity. Well, how to do today? Type 3 myoma are also supposed to be implicated for implantation failure, but how to identify? There is no projection inside the uterine cavity, so that is where one has to be a little bit, tricks have to be there up your sleeve, where you can see that you reduce the pressure and you see the bulge of the fibroid coming, so you know that this is where the location is. If you can imagine that if I have to resect this fibroid, I'm going to damage or remove so much of the endometrium, whereas when I have with the scissor and I'm going to enucleate, I'm not going to resect off the endometrium, whereas I'm just cutting the endometrium and trying to reach the fibroid apex first and then the fibroid base. You can see how beautifully you can, separate it from the adjoining fiber. That's how you can, use the same scissor for rather separating the fiber, for retraction, for cutting, and pushing it into the uterine cavity. So this is how a type 3 fibroid has to be managed today, not by resectoscope, especially if you're dealing with the reproductive age group. For obvious reason, if you're doing with a patient purely for menorrhagia, you would want more of the endometrium to be damaged, and using a resectoscope is absolutely no problem. But as far as when we are talking about safety of hysteroscopic myomectomy in reproductive age group, maybe this is the better way of enucleating and preserving the fertility, rather implantation potential much better. You can see we have entered between the space and of the fibroid and the pseudocapsule and brought it down into the totally into the endometrial cavities, almost type 2. Now you can use the HTRS to cut off the slice of this fibroid and remove it out totally. Well, there are enough papers to tell us that you can leave this fibroid inside the cavity. They will have no blood supply, so they will shrink in size and may be expelled over a couple of days. So you need to do just a sonography. So even if you cannot retrieve a fibroid, you can just take a small biopsy and then leave it inside the cavity. It will fall off. Well, another way of reducing the bleeding and reducing the fluid absorption, because the vessels are the one which will absorb the fluid. So this beautiful trial said about that vasopressin injection into the hysteroscopic myoma will obviously take care of the fluid deficit, the time of the surgery, and improvement of clarity. So this is a very good way of doing it. You can dilute the same 200 ml of saline in 1 ampule of the vasopressin and then inject just about 20 cc through the hysteroscopic needle, and obviously around 20 ml is what is required, not more than that. And you can see such a vascular fibroid will become much less vascular in just a minute, and you can see the blood has totally rolled off, and then you can use this HTRS to remove the remove the fibroid. I wouldn't run the whole video for want of time, but use of vasopressin is something we do use in certain cases when the vascularity is something very high. Post-hysterectomy, the myomectomy question is how long you will wait or tell the patient to go for fertility treatment. Obviously, I would say 2 months is the minimum, but how to prevent adhesion? Because you saw that 31% chances in the single myoma, 45%, though in India, we all tend to use the intrauterine balloon or the Foley catheter pediatric. There are obvious hyaluronic acid gel which are available, but not that easily in India. And studies have shown that they are very good. You have to just push it inside the cavity, and they have found significant reduction. Is relook a must? I would say definitely if there is multiple fibroid and I'm treating an infertile patient, definitely I would say office hysteroscopy, where within 5 minutes without anesthesia, we can look into the cavity. But yes, if there is a fibroid which is not completely resected, what to do? That there are enough evidence to say that all small fibroid which has been left behind need not be removed unless you see that the patient's symptoms like menorrhagia or AUB is not improved, then only you go and remove it. And if it is in such a location where it might prevent implantation, again, that is the time when you may go in for a pre-procedure. But hysteroscopy always believe that you have a second time always. None of the surgery, you can do it in 2 settings. Anytime if you feel that the patient is going to complication and don't want to do, you just stop the procedure and take it after a couple of days. So you will be saving the complication and pushing the patient into the
Remember the importance of preserving the pseudocapsule, especially for women like me who wish to become pregnant in the future. Be aware of potential complications during surgery, especially when treating large and deep fibroids, which may include fluid overload and bleeding. There is no ideal tool for this type of surgery. Sometimes the perfect surgery requires more than one device.
Thank you for a patient hearing. I hope I obviously answered all the questions. I had to record it on Zoom because I'm traveling to Indore, but I'll try to join when I'm in the car traveling to the airport. Thank you.
Thank you very much, Dr. Krishna Kumar, sir, for a comprehensive talk, all the lovely videos, including that AI video at the end. And I would request our chairperson, Dr. Rajeshri Katke, to introduce our next speaker, Dr. Rajesh Modi, sir.
Thank you, Pratik, sir. May I have this introductory slide of sir?
Sir, you can go ahead and share your screen.
Yeah, it's a great pleasure to introduce Dr. Rajesh Modi, sir. He's a gynecologist and endoscopic and robotic surgeon, Vice President of FOGSI 2017. His pioneer technique in the daycare laparoscopic myomectomy, lap myomectomy, Dr. Modi's aquadissection technique, lap tubal recanalization, Dr. Modi's recanalization technique and instrument set, Dr. Modi's signature needle holder for lap suturing, and the web education with live surgical streaming on Facebook, YouTube, and the websites. He conducts fellowships and the short courses for the gynec endoscopy since last 12 years at Akola in India, and he's a director of the Akola Endoscopy Center and Akola India and consultant with the Nanavati Hospital in Mumbai. So basically, sir is, more in a gynec endoscopy, and now he's coming into the robotic also. So, sir, congratulations to you, and we would like to listen from you about the laparoscopic myomectomy.
Thank you so much. Thank you very much for your kind words, Dr. Rajshri.
Yes,
thanks to Dr. Sheila Mane for organizing the wonderful program and for the opportunity to be a part of this. Since we are running a little short on time, I'll directly start with the video part. I'm going to be talking on something which is very close to me and special to me, the myomectomy technique. So the concept of aqua dissection for lap myomectomy is basically to introduce large quantities of saline with vasopressin into the uterus, replace the blood in the myometrium for a short duration. Vasopressin will cause the saline to be held in place for around 20 to 30 minutes, during which time we are supposed to finish separating the fibroid and at least doing the one layer closure. So this is the vasopressin injection needle which is going into the myometrium, 1 inch into the myometrium. It should not be on the upper surface of the fibroid. It should be towards the myometrium. The needle is pointing towards the myometrium, single point of insertion, and for this large 8-9 centimeter posterior wall fibroid, complete 400 ml of normal saline is being injected. And you can probably see on the screen the uterus is becoming blanched and marble white. So 400 ml is a huge quantity of saline. That's, if you imagine the bottle of saline, half a liter bottle of saline, 400 ml is getting injected. The saline replaces the blood entirely in the myometrium. The vasopressin holds the saline in position for about 20 to 30 minutes because of the severe vasoconstriction. The saline also finds the path of least resistance between the myometrium and the fibroid, and it enters into the capsular plane on its own, because of which there is ease in removing the fibroid outside, and that is why we call it as aqua dissection. We are not actually using forceful jet pressure, but it is the saline which finds its own path around the fibroid. So even in the case like this, where there is a submucous component, the endometrium is lifted away from the fibroid. Even if you have the endometrium which is getting exposed, whether it opens or it doesn't open, it really does not make much of a difference from the healing perspective, because you're not using current, you're not using energy source. So there is no ischemic tissue that you are leaving inside. So the entire posterior wall is opened out and there is no bleeding. So this is what happens when you use the aqua dissection technique. I'm cutting open to make sure that this is not another fibroid. You can see the endometrium now pouting out. Because there is no active bleeding, because there is no active oozing, you have a nice 10 to 15 minute window where you can place your sutures optimally. Otherwise, usually what happens is when you're doing a lap myomectomy, if there is too much of bleeding, oozing, and the tissues are getting obstructed because of the blood, you become a little panicky and the approximation is suboptimal. The uppermost layer right now, what you can see is what we label as a baseball stitch. So the baseball stitch is an inside-out stitch. The serosa buries below the opposite layer. So at the end of the suturing, you don't have much of raw myometrium pouting out. You do not have much of suture material exposed in the peritoneal cavity. This allows the healing to happen without adhesion formation. So no active bleeding, very minimal raw myometrium pouting out, very less amount of suture material exposed in the peritoneal cavity is what gives you healing without adhesion formation. The suture material which we are using is barb suture, which is now become the standard for suturing laparoscopically. It becomes convenient to close quickly. A single double needle foil of barb suture is okay to close the 8-9 centimeter posterior wall fibroid in triple layer, as you can see over here. So this is the end result. No current use, no cautery use, no dead tissue in the myometrium which has been sutured, and that is why the healing is going to be optimal. Another consideration, now suppose there are multiple fibroids. So in open surgery, what you would prefer as a tunneling incision, that you do not want too much of incisions on the serosa. Here it is the opposite. You can see the left almost lateral wall fibroid is being taken out. The injection has been made into the uterus or the myometrium, not at the base of the fibroid, not in the fibroid, in the myometrium. Once the fibroid has been removed, when we see the other fibroids, usually then you have to take a decision on whether you want to take a separate incision or you can try to do tunneling. Now, tunneling in laparoscopy becomes really very challenging. And another important point here, you need to have 2 myoma screws for traction. So here you can see that I have 3 ports besides the camera port. The left hand is holding the tooth needle holder, which is a very sturdy instrument. And then the 2 myoma screws give ideal traction for the counter traction, which is exerted by the needle holder. And this allows the fibroid to pop out easily. You have to be a little quick and fast. So now here you can see. Now this particular situation in open surgery, you would probably put your finger inside and tunnel it out. But laparoscopy, I am more concerned about the suturing part being optimal. So here, even if I try to tunnel out, the damage to the myometrium is going to be much more than the benefit. So for laparoscopy, typically we prefer to have separate incisions on separate fibroid, unless it is within the same area of the previous one. Quite often you have 2 or 3 fibroids on the posterior wall, 2 or 3 fibroids on the anterior wall, and then you end up suturing in 2 or 3 locations on posterior wall, 2 or 3 locations on the anterior wall. Generally speaking, whether the cavity has been opened or the cavity has not been opened, most of the patients who have undergone a lap myomectomy tend to undergo an elective cesarean. Though I would not say that that is a rule to follow, because you can definitely consider giving a trial of labor for these cases. One of the advantages which I feel is because current has not been used, there is no ischemic damage inside the myometrium, healing is not a problem. So healing is optimal. There is no scar weakness. There is no scar dehiscence. Touchwood, in my own practice of 25 years, I have not encountered any feedback from any patient who has suffered with a weakened scar or a scar dehiscence due to pregnancy. Almost everybody has delivered nicely. Like I said, most of them go in for an elective cesarean. Sometimes you have multiple large fibroids, like in this case. I am going to fast forward a little bit. This is just another similar fibroid which we have put. Cavity was opened quite widely, but again, suturing happens. Now, the effect of vasopressin will last for around 20 to 30 minutes. So if there are multiple large fibroids which you have removed from anterior wall as well as posterior wall, and the surgery goes on for 45-50 minutes, you can notice that the effect of vasopressin is lost by the time the suturing is done, and some amount of oozing will happen. But for a fibroid or multiple fibroid, up to 400 ml blood loss is also fine, though it never really comes up to that. Bleeding is not something which should be a deterrent, because you can always replace blood. Now, this is something which is very relevant in laparoscopic myomectomy nowadays. This is called as contained morcellation or in-bag morcellation. So this is something which we have started using for the last 2 years only for every case. This is an endo bag, a sterile endo bag, which is placed in a folded manner in an introducer. Now, this is how it goes inside the abdominal cavity. You have to put the bag inside, then put the tissue inside the bag, get the mouth of the bag out. So this is tedious for the first 20 cases. I used to do laparoscopic myomectomy without the in-bag morcellation for almost 20 years. Then we started doing the in-bag morcellation. For first 20 cases, 30 cases, it was a pain. The myomectomy used to get over faster. The in-bag morcellation would take a little bit of a struggle and time to finish off, but you get tuned to it. And after some time, when you get tuned to it, you do not get stuck in different situations. So this is a bag which has come in. Now we are counting and putting all the fibroids in the bag. The bag is very surgeon friendly as such. The mouth opens very comfortably, so you don't have to struggle to open the mouth. The bag is shaped in J-like pattern. So this is the mouth of the bag. The tissue is already inside the bag. I prefer to use the upper side port. Some people prefer the lower port. I prefer the upper port for the morcellation to go inside. This is the mouth which has come out now. So now bag fibroid is in the bag. And then you have the tail. The tail is railroaded into the 10 mm port. So as much as the technique of myomectomy is important, being able to do a correct in-bag morcellation has also become very relevant in today's scenario, where patients are quite Google aware and they are themselves consistently asking about these kind of situations. So this is a tail which has come out from the 10 mm port. Railroading becomes a little quick and easy to push the tail out. Other option is to use a 5 mm scope from the side port, put the 10 mm claw, hold the tail and pull it out under vision. But then from my 10 mm scope to change to 5 mm, especially if I'm using 3D, it's become a little bit of a time consuming factor. You can see that there is a hole in the tail from which we are introducing the 10 mm cannula. This gets introduced easily. The plastic guides it properly into the same cavity. So you don't really have to end up struggling to put the cannula back. Once the 10 mm trocar is going into the tail, then you shift the pneumoperitoneum in the 10 mm. Now this creates the pneumoperitoneum inside the endo bag. So now you have the bag, the tissue in the bag, and the pneumoperitoneum is also in the bag. Now in this case, when we do the morcellation, the tissues which are going to be scattered around will be contained within the bag. And that is exactly the reason why it is called as contained morcellation or in-bag morcellation. A 15 mm morcellator is usually what is preferred. There are multiple types of morcellators available in the market. If you are good enough to do a lap myomectomy, you are good enough to do an in-bag lap myomectomy. So don't skimp this particular step. You have to, when I started using, like I said, for the first 20, 30 cases, it was a pain and a struggle. So first 1 year, only simple cases we would do in-bag morcellation. And then from the second year of work, we started doing all cases as in-bag morcellation. Now it has become a routine that all myomectomies have to be as an in-bag morcellation. Not only for the patient's safety in preventing an accidental leiomyosarcoma from spreading, from your personal safety as a surgeon, because everything is recorded. And in case there is a negative report and you have not done an in-bag morcellation, it becomes a little challenging for the explanation to be given. Thank you all for a very patient listening.
A very nice presentation, video presentation, and very nicely told, sir, about this endobag morcellation, because we have already 2 cases came to us with this. 3 years back, and it has been done one of the corporate hospital, and the endobag means previously it has been not used, and she has loaded all the stromal, leiomyosarcomatosis all over the abdomen. So it is a very good practice. Though I think this is not FDA approved, na sir?
This is now FDA approved.
Now FDA approved. So one has to be, take a good selection of cases. And what about about that aqua dissection? If suppose some of the surgeon, it takes much of the time, then they have to tackle the proper suturing for the, again starting the bleeding from the dilated vessel.
Yes, because repeat
That is what
injection I have tried,
the
it does
next
not make
point.
much of an advantage when you try to repeat inject, because the myometrium is already cut open, everything leaks out into the cavity.
Thank you, Dr.
And
Rajesh Modi, sir. Thank you,
people want
Dr.
to know
Rajesh
the
Modi.
name of bag. I
Brand.
think there are questions
Okay.
regarding that.
It's a
Rajesh.
Versator company morcellator, Viol company morcellator from Bombay. Then the bag name is Morsafe. Thank you, Pratik, for the invitation and the opportunity to be a part of the
Thank you very
program.
much, sir. Look forward to having you more often on the ICOG.
I did mention it to you, so I said yes, Rajesh has to be there.
Yes.
Can we have Dr. Mahesh Korigol introduce our last speaker for this session, Dr. Vidya? But we are already running late.
Yes.
Good evening, everyone. And I'm very happy to introduce Madam is a senior person from Bangalore Rugby Society and our past president also. And Madam is a very senior most person on BSOG who has done conducts lot of conferences and very active at national.
Can you be a little louder, Mahesh? Yeah.
Yeah, madam. So Madam has presented a lot of publications and papers. She's a president of KASOGA, Secretary General of KASOGA, President of BSOG, Joint Secretary, ICOG member of Governing Council, member of IAG, and many laurels to Madam's credit. And she's a senior member of BSOG. I'm very happy to invite Madam for her talk. Please start, Madam.
Thank you so much, Mahesh, for the nice introduction. At the outset, my sincere thanks to Sheila Madam and Dr. Pratik for this opportunity. It's really nice to do a program for ICOG, sorry. Sandhya, please come, just go. ICOG, because I've been training students for ICOG and it's a great opportunity. And when Dr. Pratik asked me what you want to talk, I said, I'll talk about difficult myomectomies. This is because, This is because I have been doing a lot of myomectomies and with endometriosis and presentation. Yes. A lot of live demonstrations also. And as Dr. Rajesh said, in-bag morcellation also is, just bring this aside, yeah. In-bag morcellation is something which we have been doing for quite some time. And, but when to do in-bag morcellation and what to do in difficult situation. There are so many times we have difficult, screen is sharing, but it's not. Can you see my presentation? Yeah.
Yeah, it's just open. You can go full screen, slideshow.
Yeah. Okay. So I'll just directly go to, not here. Screen share.
Bottom right.
Yeah.
Perfect.
So thank you so much. I will not go to all these details. I'll directly go to the challenges. How to optimize the results in myomectomy. We've been talking about simple myomectomies. We've been talking about hysteroscopic myomectomy. But how to optimize the results? Because we have to do a clinical examination, USG and MRI, counseling has to be done. Sometimes we may have to do a hysterolab approach and hysteroscopy. You saw a good number of cases which was done by Dr. Krishna Kumar. So we have to discuss the complications, and sometimes when you're doing myomectomy, you have to tell the patient that these are some difficult myomas and I need to map it. In our center, since I do my ultrasound myself, I do a transvaginal and a transabdominal one, though MRI is done to know the number of myomas. Sometimes a small lateral myoma could be missed. We do an MRI plus a complete evaluation by me just to plan my surgical steps. Of course, depending upon the size of your myoma, open surgery will be like this. Da Vinci, I would say, because now I've started doing robotics also, Da Vinci is not good for, or robotic is not good for myomectomy because you have to change over once again for morcellation, and doing smaller myomas, it is really difficult. Or maybe I've been a lab surgeon so many years, it has been difficult. But depending upon the area and the number of myomas, you can plan your ports also. So that depends upon your complications. And of course, the incision, when you're doing laparoscopically, you can go through any incision, oblique, posterior, elliptical, and transverse. And this is a normal myomectomy. Well, I won't go to that. But what are the challenges you meet? Broad ligament myoma, cervical myomas, previous surgeries, multiple myomas. When I say previous surgeries, endometriosis, adhesions, and large myomas. So site and location is very important. This was one of the broad ligament myomas. Your biggest challenge is how to reach, how to approach, and what incision to be put. Just see the maximum bulge of the myoma. And once you see the maximum bulge of the myoma, you can take an incision there. Sometimes when it is in the broad ligament, it will be mimicking an anterior posterior myoma. You'll think always that there is a myoma anteriorly also. But once you enucleate it, or when you remove it out or shell it out, you realize that the one which was bulging anteriorly was the same myoma which was posterior. And injecting vasopressin is mandatory because I inject 10 units in 100 ml of normal saline. About 100 to 200 ml I inject in vasopressin into the myoma. And see, this broad ligament myoma is completely shelled out, and this lady was not conceiving because her cervix was completely hitched into near the symphysis pubis because of this broad ligament myoma. And once you do the broad ligament myoma shelling, you see how easy it is. Care has to be taken that you don't include the tube, you don't include the ovaries, but just suture it in 2 layers. You get a very good scar integrity, and there's hardly any bleeding, and the myoma is out. And subsequently, after 3 to 6 months, this lady conceived. Of course, she had a preterm delivery, but now she's happy with 2 kids. Subserosal, let me not go into it. You have a cervical myoma. Now, this is very tempting. Once you have a cervical myoma, you just put in the hysteroscope and you will see a big bulge in the cervical canal. Well, don't even attempt to think about it. All you have to do is put in a laparoscope and realize that it is like a lantern, it is sitting on the top. Uterus is inject vasopressin, but you have to think about the ureter. So ureter, you can do bilateral ureteric dissection or you can do unilateral. In this particular case, I did unilateral ureteric dissection because this was more towards the right side. Now, the classical methods of ureteric dissection, you can go through the oncosurgeon's technique, and this is the endometriosis surgeon technique. I'm going with the medial or the posterior incision. So just bare the ureter, see where the ureter is going, and see the extent of the ureter. And once you do that, then you get very confident that this myoma is away. And when you have a posterior wall myoma, ideal would be to take a vertical incision. And if you have a anterior wall cervical myoma, go with the transverse incision where you can prevent the bladder. And here, see how close the ureter is, but just lateralize the ureter, see the extent, and that is the ureter getting into the ureteric tunnel. And once you clear that, then things become very easy. And all you have to do is just, of course, there was a small bleeder there. Then I took an incision there. I took an oblique incision because it was more towards the right side, and the myoma was getting shelled out. So you can, the moment you inject vasopressin and put the incision, the myoma will just come out. And all you have to do is remove the myoma. Now, the most important step when you're doing a myomectomy for cervical fibroids, please put in a dilator inside. Don't just obliterate the cervix by suturing it. Keep a dilator, see the extent of the cervical canal, and carefully watch that and shell out the myoma and suture it in 2 layers. So this is something which anybody can do, but these precautions has to be taken. And once you take these precautions, the cervical myomectomy becomes very, very easy. This is our own publication where we published that post myomectomy pregnancies were very easy, and there was hardly any scar rupture. We have done both vaginal deliveries and cesarean sections. Multiple myoma as well. I'll go to one more. Pedunculated myoma. You will see small pedunculated myoma, but this particular pedunculated myoma was almost up to 24 to 25 weeks. We could hardly see the uterus. In such cases, a 30-degree telescope will help you. 0-degree may not be adequate. So you inject vasopressin not to the myoma, the junction between the uterus and the myoma. That is where you need the vasoconstriction, because this place, if you give vasopressin injection, it will be ideal for vasoconstriction and separating the myoma, because this will have large vessels. Even in spite of giving all the vasopressin, you can see so much of bleeding is there. But once you shell it out, then the whole thing is out, and there can be just backflow bleeding, and you have to do a 2-layer closure. Keep a little pedicle so that you have enough tissue to suture the myoma and see how well it gets approximated. And because some amount of pedicle has to be left, and of course, remove the myoma, and whatever tissue is there, you keep a flap so that you can completely close the cavity or the incision and then give a good surgical outcome. Multiple fibroids. This was 28 weeks. So this is when you need to do a tunneling incision when you have, and you can see the adhesion posteriorly. When you have these multiple fibroids, the most important thing is her hemoglobin has to be good. You have to keep blood ready. And then you also have to counsel the patient that you may have blood loss and it'll take a long time. And maybe one or two will be left behind. That also you should counsel her. But try to do a excellent job by removing all the myomas, because she'll come back again. Or this lady was an NRI patient, so she said, madam, I want you to remove everything, because I can't go there once again after 3-4 years and ask for another myomectomy, which will be very difficult for me. Of course, after this myomectomy, this lady underwent IVF and she conceived, and she is now doing well. So look at the number of myomas. I am going through multiple incisions, and once I finish shelling out all the myomas which were near the fundus, and then there was another small myoma. So there were almost 12 to 14 myomas, and once I finished that, suturing it, see, you have to be very good in suturing also, and fast, because it will cause a lot of bleeding. So you should try, though there is blood, you should try giving a good hemostasis. So the fibroids which were obstructing my vision were removed, and then I realized that there were more myomas, some 4 more myomas. So then I made the posterior incision, and you can see that there was some amount of bowel adhesion, and posteriorly we removed, and then there was another anterior fibroid. So we had kept blood ready, and then we gave her enough blood, and you can see that whole job being done. So the best way is to get a good outcome is tackle the complication. Team has to be good. Do a bed suturing, and completeness of the procedure is important. This is the meta-analysis when they compared with laparoscopic and open myomectomy, and everybody agrees now laparoscopy is good. Then degenerated myomas. This is a big challenge. When you have degenerated myomas, the problem is shelling it out, making an incision, and then you can also have the plane being completely obliterated. So this lady had a red degeneration of myoma, and I was trying to shell it out. Look how bad it is. And of course, we had done all the pre-op to rule out malignancy. It was just a degenerated one. We got an MRI done. But look at the planes. The planes are so bad. I can hardly sort of put a myoma screw. And I had to just use scissors, and then sometimes I use a tenaculum, but I'm just dissecting it away. I'm not pulling the myoma, but just dissecting the flaps of the myoma away, so that I do a complete job. And once you finish that, the bleeding is not an issue here because it is degenerated. There's hardly any vascularity. But look at the myoma, which has turned completely red. And calcified myomas, the biggest challenge is morcellation. This was one of the calcified myomas where we did bilateral uterine artery ligation, because we were doing myomectomy to save the uterus. So morcellation is the biggest challenge in calcified myomas. Your blades will go. So you have to have 2-3 blades, or your morcellator blades extra. Don't just keep one blade. And especially if you are going from one center to another, keep a spare blade in your car, because anytime anything can go wrong. I always keep 2 spare, because if one conks, one more is there. And calcified myomas gives you a big challenge, but the bleeding may not be much. Then, of course, when you have myoma and endometriosis, this was one of the myomas where I thought it was a submucous myoma, and I thought it would just shell out. But I completely made an incision, and I was wondering where the myoma is. They had ultrasound was done, and it was 5 centimeter, but this was more than 6 centimeters. It was sitting through and through the whole cavity. See, you can see such a big myoma there. And of course, I entered the cavity. But once you enter the cavity, respect the cavity. You can just approximate it without including the endometrium, or respect it and take sutures with Vicryl. Don't include the endometrial cavity, but just above the endometrial cavity, put interrupted sutures and then close in 2 layers. See, that is very important. So once you close in 2 layers, what happens is scar integrity is very beautiful. And this patient, when she delivered, I was really happy to look at the scar because there was no issue at all. Of course, I did a section, but it was a 3.5 baby. The weight was 3.5, and the patient was fine after the. Yeah, this one I won't go. This is bilateral uterine artery. This is with endometriosis. This was one of the videos I wanted to show you. I think I have some more time now, Dr. Pratik. Do I have
Quickly,
time?
2 minutes, ma'am. Yeah, we can take this one last video.
Yeah. So this is with outside, she has undergone 2 endometriosis clearing, but she had a fibroid and that fibroid could not be reached. So first problem was bowel adhesions. So we released the bowel adhesions, which was really bad. We could hardly sort of get a plane. Then I had to go and identify the ureter. See, in such cases, identifying the ureter is most important. And 2 embryo transfers, one she conceived, the other embryo transfer had failed for her. And even what she conceived, there was an abortion because of this huge myoma. Now, reaching the myoma was the big challenge. See, I can see the myoma, but I can't sort of shell it out. So I had to do further bowel resection, separation, because of the bad endometriosis. And once I got the plane, see, once I separated the bowel, I could see the myoma, which was almost a broad ligament myoma. And posteriorly, ureter was completely compressed and it was pulled to one side. Then, after doing so much of dissection, then I could bring the myoma from the pelvis. I could bring it out, and then we did the myomectomy. There were about 4 myomas. And this was the biggest challenge because we had to safeguard the ureter, you have to safeguard the bowel, and then do the myomectomy. Of course, now she's ready for embryo transfer, and I'll be shortly doing it for her. So this myomectomy, 4 myomas when I removed, it was a big challenge. So sometimes myomectomy is not as simple as we think. It is challenging, and reaching the myoma itself is a big challenge because in this particular case, even with 3D, it was so difficult because you have to dissect the bowel first. So that so sure technique, which we use for endometriosis, comes into place in all these difficult cases. So first dissect the bowel, then separate the ureters, and then do the myomectomy, and then you get a normal sized uterus. So suturing can be single or 2 layers, barbed or V-lock, whichever, but learn suturing. That is my message to everybody. Do good suturing. You can do an excellent myomectomy. I will not go through all this because of paucity of time. But whenever you have a myomectomy, prepare the patient well, map the fibroids, make proper incision, and then, if necessary, do in-bag morcellation. Since Dr. Modi has shown that, I will not go through that. Robotics is not good for myomectomy. Hysterectomy, it is good. But myomectomy, somehow you have to do a combination. So I wouldn't vote for robotics in case of myomectomy. So myomectomy is the best option, lap myomectomy. Optimizing results gives you a good outcome. Preserving the fertility should be your priority. Thank you so much for your kind attention.
Thank you, Dr. Vidya Bhatt. Fantastic selection of videos, and shame that you ran out of time. There was so much more that we would have heard from you. We'll invite you again, of course, on the ICOG platform to watch more of your videos. I know you're already there in the reproductive medicine course since many years. Thank you very much for your contributions to ICOG.
Thank you. Thanks a
Thank
lot.
you. Nice videos, Vidya. Very
Thank
nice.
you, ma'am.
Thank you, Dr. Sheila and Dr.
Yeah,
Pratik.
thanks. Yeah.
It's mesmerizing videos and everything. Lots of learning points. So do we have a time for question answers?
Yeah, there are about 4-5 minutes
Yes.
which we can use to take the questions. I think Dr. Kavita Bhatti is here. I would request her to
Yeah.
take only
Yes,
the relevant questions.
Good evening, sir. So I think the chat box is full of appreciation for the speakers and for the organizers, Dr. Pratik Tambe sir and Dr. Sheila Mane. And I think we'll take up few questions. There's a question, is DJ stenting required for cervical fibroid?
No, if you know ureteric dissection, it is not. But if you have the provision for ICG injection, that you can do, because stenting the ureter will damage it further unnecessarily. So if you can't do ureteric dissection, or if you are not trained to do ureteric dissection, use ICG. And if you don't have ICG also, we have cadaver courses in Bangalore. Please come for the cadaver courses. We will teach you how to do ureteric dissection.
Can I add one thing? Because we have been taking fibroids around the size of 30 kg also, and 12 kg myself. We operated, basically it won't go to the laparoscopy or the robotic one, but in that sometimes the ureters there, the course is diverted and it has become very close at the base of the bladder and all. Their bilateral uterine stenting is very, very important, because all varieties and difficult myomas, either myomectomy or the hysterectomy, I have experienced in that. So there is a role of, I think, bilateral stenting in a very, very difficult, though we are trained in a oncologic ureteric dissection also in some cases.
Thank you,
Ma'am,
Dr.
I
Katti.
would
We
slightly
have
disagree in this, because ureter is a retroperitoneal structure. And whenever there is a myoma, it is always to the uterus. The classical teaching of what we had in Boni's, and that a broad ligament myoma, pseudo broad ligament myoma, is not true, ma'am. It is, ureter is a retroperitoneal structure. So whatever large myomas, I showed you the previous 28 weeks uterus, wherein it is confined to the uterus itself. But when you have endometriosis with that time, maybe a person who's not well versed with it, they can use ICG. But somehow ureteric stenting is something which will not help in many of the cases. So learn ureteric dissections, because we are taught as postgraduates to get scared of the ureters. But if you learn ureteric dissection, that is one of the best things. Yeah.
I am doing gynec-onco since last 20
Madam,
years.
can we
I mean,
stop
we
this
can
discussion
have
because we
more
are here
discussion
with
on the
us?
gynec
We
section.
have with us
we are
Dr.
running short
Sarita
of time.
Bhalera,
Yes, yes.
Vice Chair elect. Can I
Yes.
request her to please unmute? We
Yes.
missed you at the beginning
Yes,
for the
yes.
inauguration, ma'am.
Yeah, hello. Yeah, thank you to Dr. Sheila Mane and Dr. Pratik, and for giving me this opportunity. And I'm sorry I was stuck, but I had the pleasure of listening to Dr. Vidya Bhatt's talk, and I've been listening to the talks, and I think it's going fantastic, and I think it's a great masterclass to start off with. Congratulations to the whole team.
Thank you, ma'am. Thank you very much. I think we'll call this session a close because we've
I
overshot
welcome
our
Dr. Kavita Bhatti. I think she also joined.
Thank you so much, ma'am. Thank you.
Yeah, Dr.
And it's
Kavita.
been wonderful watching the videos. I think they were really beautiful videos, very clear.
Yes, I would like to thank all the chairpersons of the session and the wonderful speakers with their precise videos. They made the surgery so clear and understanding, and was very beautiful. How to manage the surgical management of the fibroids was dealt in a very beautiful manner. So, with the close of this session, I would like to move forward to the third session, which is a panel discussion. And we have with us to moderate this session Dr. Parul Kotadwala and Dr. Renu Singh Gehlot, and fibroids from principle to practice. So, I think this is going to be a very interesting discussion because we have with us renowned panelists also and very experienced ones, Dr. Dinesh Kansal, Dr. S.P. Jaiswal, Dr. Upma Saxena, Dr. Damodar Rao, Dr. Padamja, Dr. Sanchita Dubey, Dr. Shaiju, Dr. Tabassum Dalla. So I welcome the moderators. And can we have the CV of moderators, please?
Dr. Renu, you can go ahead and share your screen.
Yes, good evening, everyone. So thank you, ICOG
Parul,
team. So Dr. Parul will be sharing the screen. Sir has
Dr.
joined.
Parul, we know
I see
is
sir's
the
video is
Short
off.
CV. Just
past
Richa
chairperson.
wants to introduce the moderators. Yeah.
Dr. Parul, we all know him so well. He is the past chairperson of ICOG and has worked very hard to raise the levels of ICOG. and he's a senior consultant professor and head department of ONG, Sal Institute of Medical Sciences, Ahmedabad, and also runs a Kodawala Women's Clinic and a senior. The next moderator is Dr. Renu Singh Gehlot, a renowned laparoscopic surgeon and infertility specialist from Kanpur. She is a diploma in gynae endoscopy from Germany, and she is ICOG accredited trainer also for gynae endoscopy and reproductive medicine. So now on to you, Dr. Renu, for the next panel discussion.
Yes. Thank you,
Okay.
everyone. Yeah.
Am I audible?
Yes, sir,
Pratik,
you're audible. We can't see you. Your
yes,
webcam is
yes,
off for
but
some
I am
reason.
trying to activate my video, but it is not showing. What is the problem? Can you suggest something?
Maybe, is there a physical shutter that is covering the webcam?
Yeah, sometimes there's a
Laptops have
physical
that.
shutter.
No, there is no shutter.
Then probably you have disabled it for privacy reasons so that Microsoft and Meta cannot spy on you. And you've forgotten how to undo that setting.
Now, how can I redo that setting?
If you can go to the small little button up arrow next to video.
Yes,
In the
that I
bottom
click.
left. Usme
Yes.
integrated camera, if you select, it should automatically switch on your webcam.
There is no such thing. It is HP, SMP camera, blur my background, auto frame my video, adjust background and effect, choose video filter. Should I click that?
No, sir. It is the correct webcam which is selected. Is it a separate webcam, not on your
No. It
laptop?
is on my
It's integrated.
Mirror my video preview. Is it like that? No.
No, sir.
Camera, I have mentioned my HP SMP camera. Hard
Yeah.
drive.
In
No.
the video settings.
Sir, host tools, there is a logo of host tools. Please click that.
Sorry, host
tools.
Where is
host
it?
to
Next
I
to
don't
share.
see any message.
Next to share is the logo of host tools before the
I've
AI
sent you a
companion.
request to start your video.
Start my video.
नहीं अभी भी नहीं दिख रहा. Some
Host
technical
tools I have
glitch.
started. Share screen, chat plus, rename themselves, unmute, start.
I think you'll have
video.
to go ahead without the webcam.
Start
Okay.
start video.
Start video is on. And this has happened for the first time. So I am really confused that
Sir,
what
it's
is the
Murphy's
problem.
law. Whatever can go wrong will go wrong.
It is, yes, Mary's law. So let us start off without the video. Is it okay?
Yes, sir, that's perfectly fine.
Because unnecessarily we are wasting time. I'll share the slides. Dr. Renu will be taking the bulk of discussion because I have a sore throat a little bit.
Okay, sir.
Okay, I'll just
Ji, sir,
put in. So,
we can see.
Can you introduce all the panelists who are with us?
Yes. So we have esteemed panelists with us, Dr. Dinesh Kansal, Dr. S.P. Jaiswar, Dr. Upma Saxena, Dr. Damodar Rao, Dr. Padmaja, Dr. Sanchita Dubey, Dr. Shaijas, and Dr. Tabassum Tala.
So you may see their pictures and know them. See, basically, entire gamut of fibroid management and everything has been already discussed. The surgery part is also discussed. And we will be discussing the application of this knowledge, that in which situation, how do we use management. One little thing I was a little bit disappointed during the discussion was everyone has sort of given high ball to endoscopy. But none of the speakers have spoken anything about need for an open surgery as well in fibroids. So maybe in discussion, this may come up that there are situations where endoscopy may not be the right approach. Anyway, so let us get on. So why we discuss fibroid? Why we preserve the uterus? The rules of engagements are that all the panelists may sort of disagree with each other, but in case of disputes, the moderator's word will be final. And we have very little time with us, about 40 minutes. We have 8 panelists. So approximately you can say if you add both of us, we have 4 minutes each. Okay. You all know the myoma management can be medical, can be surgical, or now emerging is non-surgical alternatives. And myoma management can be conservative or laissez-faire, which has been my forte. I have many a times just remained lazy handling the myoma. We can have medicines to stop growth or symptom relief. We can perform surgery for conservative surgery for retaining the uterus. We can use less invasive procedures, and if none of this works, hysterectomy is, of course, the ultimate goal. But if you notice, most hysterectomies have been done with one indication, and that is AUB and fibroid. So let us discuss the case scenarios. Dr. Renu, you can pick up from here.
Yes, sir. Okay. So she's a case of 42-year female, P2, 2 live well healthy, and she presents with history of menorrhagia. And on ultrasound, there is a sign of 4 centimeter submucous fibroid. So now, how will you manage the patient? So one by one, we can ask our panelists to just give your crisp management tips. Any one of you can start?
Okay, I thank you very much. This is Dr. Sanchita for involving me in the first ICOG Master Series. It is very clear that if it is a submucosal fibroid, the first approach should be a hysteroscopic management, as discussed in the previous talks also. And but again, one should know their expertise, and if they are expert in doing it, and the right choose of right instrument is also equally important in this. Though in her case, fertility is not an issue, but yes, menorrhagia is the concerning factor here.
So I just want
Anything
to
between
add,
3 to 5 centimeters, hysteroscopy can be preferred. If it is more than 3 centimeters, experienced hysteroscopists should only perform this kind of surgery.
so I just want to add in this that she's 42 years. So I'll definitely do an endometrial biopsy to rule out hyperplasia and malignancy, and also look for other fibroid. So I'll do some ultrasound TVS to whether it's a single fibroid, which is submucous, or it's associated with other fibroids in the uterus. Before
So the
I
next
go ahead with the
question, yes, madam. So the next question comes up, what is a pre-op workup before hysteroscopy? Like along with the transvaginal sonography, where we are doing the mapping, what other investigations will you like to go ahead with? Specifically with hysteroscopy.
For the as the patient needs anesthesia, so pre-operative workup should be done for the anesthesia purpose, especially the patient is 42 years of age. In that situation, we have to go for the all investigation which is required for the PAC. And along with that, if you go for the FIGO classification, it comes either the 0 or 1, depending on how much. If it's a polypoid, then it will come into the 0. And the size is between, and the patient is symptomatic and size is less than 3 centimeter. And before that, as Dr. Upma says, whenever we are planning for the surgery, we have to do the mapping of the fibroid also, because there may be more than one fibroid. One is the symptomatic, which is because of some mucus. There may be intramural or subserous also. So the mapping is required, and the ultrasound is the best to do for the mapping. But in some condition, we need advanced
Ma'am, in
like
this case, we
MRI.
have already done a transvaginal and we know it's a submucous fibroid,
A
right?
3D scan can be done for her case.
Yes. For now, this is the question whether you will prefer a 3D transvaginal sonography or a MRI or both for mapping the fibroid, and why we need that mapping. What is the classification system specifically to be used before hysteroscopic myomectomy?
So regarding the classification system, we use either SC classification or Wamsteker classification. and or a LASMR, because all these help us to know whether they can be tackled hysteroscopically or not. So that is a must.
I have
So
one
that's why we
question
do
to all the panelists. Hello.
Yes, sir.
See, any of you have been using this LASMER's classification? How many of you are actually using it?
Actually, most who are doing hysteroscopic myomectomies, they are using more of LASMR classification. Most of us are doing just one sticker only.
So do we record that in our case sheets?
It should be recorded, ideally, before you tackle.
Okay, so that is where it comes down to. That is what I wanted to discuss. See, we know theory part, but what we do actually in our practice, and where it matters most and where it is okay. In teaching institute, I believe it should be recorded, the classification and the numbers. In a private setup, a person who is himself checking the patient and who is himself operating, perhaps they may get away without putting all these numbers, because there are issues that we cannot stick to the classification 100% in actual practice. We may have to look at the patient's need, and accordingly we may deviate from there. Okay, so let us get on with the
So,
discussion.
sir, when we talk about the detailed evaluation, I think ultrasound and 3D ultrasound is a good enough investigation to proceed further. Another very important thing which we should be looking out for the fibroid is the vascularity, so that you can be prepared while performing the surgery. And another important thing is to see the thickness of the myometrium over the fibroid. That also is for this large fibroids like 4 centimeters, we should be knowing how much is the myometrium stretched over it. So that's also very important.
So that is one of the most important clinical point, that the thickness of muscle outside the fibroid has to be at least 5 mm. Otherwise, don't attempt it, do it laparoscopically. Because if it is too thin, you will have a speculation and future rupture if it ends up in a pregnancy.
Yes.
Yeah.
I think Dr. Krishan Kumar just told us about enucleation technique. I think if we start using it much more, this point will be not so
I
relevant.
showed it here. If you had seen this, that we did enucleation like that. We lifted it from the base and kept on twisting it till it came out. Okay. And you can see the crater also once it is taken out. So that is, of course, as long as possible. And secondly, as you can see here, in resectoscope also we put a linear cut. It is not removing all the endometrium over the fibroid. Put a linear cut and tease out the fibroid from base from this linear incision, rather than using a resectoscope all around and removing a lot of endometrium. So that one has to be as long as possible. Again, nothing is written in stone in our practice. Any of you are using this prior
Yes,
to?
I have one thesis on. I've given a thesis to one of the candidate, Ulipristal, and used in many patients, but there's not much benefit I got in my study. So, and about the GnRH, definitely we can use for to gain the time and to reduce the size of the myome. That is the only thing. Otherwise, after that, we can go for the surgery.
Yeah, if you actually look at the evidence, the primary use of preoperative medical therapy before doing a hysteroscopic myomectomy is primarily intended for maybe type 2 fibroids rather than type 0 and 1, where you could probably actually reduce the size and reduce the morbidity associated with hysteroscopic myomectomy. So that is one opportunity where you can actually think of using, because there is good enough evidence that supports the use and it giving more benefits than the risk associated when you use it for type 2 fibroids.
So fibroids are associated with some amount of endometrial hyperplasia because it's a hyperestrogenic state. So when we are doing a hysteroscopic resection or removal, we will be having lots of fluffy endometrium falling all over the eyes. So using GnRH analog makes it extremely bald to get this out well. So that was what I found in the experience. It's not like you use for 3 months, 6 months, not like that. Just one shot to get the endometrium to become thin and then remove it, life becomes easier. Of course, a 5 centimeter fibroid is going to be very difficult.
So this is very important to understand. Ulipristal, I think we should just forget about it because it has got a very high chance of liver injury. And in last 2 years, I think 3 cases, patients on mean ulipristal and SGOT-PT been in thousands. And
Yes.
patient, a 24-year-old girl having all these symptoms. So I think ulipristal should be left like that. If we have to do an hysteroscopic myomectomy, just 1 or 2 shots of GnRH agonist just to reduce the vascularity and to reduce the size a few millimeter definitely helps in a complete hysteroscopic myomectomy. So now the
I
next
agree.
question comes.
Ulipristal
Yes.
should be used. This is an obsolete drug
Yes,
for
this
fibroid.
message
Now
should
should
go
not be
off
used.
to
Yes.
everyone.
Because
It should not
Lipristal.
be, we have to just keep ulipristal sideways. We should never ever think about it because there are a lot of complications being reported. It has not been approved by US FDA and lot many cases are also going on against ulipristal.
This
And we have
message
no
I think need
GNH
to go
antagonists
across.
available now. So
Yeah, this
it is
message I think need to be put across
put
very
up.
clearly, as all of you rightly suggested, because if you
Yes.
look at the evidence even today, there is pretty strong evidence on one side to suggest that ulipristal being given in 4 individual courses of 12 weeks each still seems to be a very important component of medical therapy. Where if you
Exactly.
read down only, you'll come to realize that liver toxicity seems to be very significant, and that is something which needs to guide that decision whether to actually use that drug or not. So I think need to put it across very clearly to the all the delegates who are listening to us.
So
Yes.
it should
And
not
one
be
important
given
point is,
medically.
one
It should
important
not be
point
given
is
for long
whenever we
period.
are putting any patient of fibroid on any progestins, any progestin, SGOT, PT and complete LFT is must because these
I
patients they
agree.
keep on running from one center to other and some or other drug they are taking for years and most of the time they are on the verge of liver failure. So this is a very important point to be noted before giving any sort of progestins or some sort of medical treatment to these girls.
And definitely check the records of what the previous gynecologist has given, because
Mhm.
everybody seems to be using 4 courses. So that means if there are 4 gynecologists in the area, that would mean that there are 16 courses that the patient is at risk of getting. So do
Not
cross check
only
your
Dr.
records.
Dr. Shaijas, not only ulipristal, even if you are combining
High dose
norethistron,
progesterone.
sometime
Yeah,
MPA, sometime some other. So all in all, for 3-4 years, that girl is totally on some sort of progestogens, which is leading to complication. All of
very
them,
true.
they are going through liver and creating some sort of injury. Once the patient was on GnRH agonist for 12 months continuously, she was bent. D3 was 5.6 something. And then she came for hysteroscopic. She was having more than 13 submucous myomas. So we have to consider this. This is not a treatment. This is just a symptomatic relief which we are
Bio.
giving to a patient till we are doing her complete treatment.
So
So
this
now
should
comes
be
the
Unfortunately,
next
used
all
question.
this
only for to gain some time to
Yes.
exactly.
So
build the
This,
hemoglobin
particularly,
or
yeah.
prepare the patient for surgery.
So
And
Whether it is a
particularly
married,
for
unfortunately,
this
unmarried, whatever,
case,
ultimately she will land up into the surgery.
correct. And
so
unfortunately,
particularly for this
this much
case,
of
I would suggest only GnRH if she is anemic and we want to buy time to build her hemoglobin, or if she wants to defer a surgery for some time, then just GnRH should be the choice. Otherwise, the surgical hysteroscopic
okay, now
removal for
because
this
she is a
particular case.
42, now let keep on moving forward.
Okay, let's move
So
forward.
she is a 42-year-old woman, and if her main symptom is menorrhagia, along with hysteroscopic myomectomy, should we perform concomitant endometrial ablation?
I will not prefer to perform concomitant endometrial ablation for all the cases, because if the myoma is the cause of her bleeding, she will be fine. But if she has got if she is obese, or she has got a history of PCOS, or she's got more possibility of endometrial hyperplasia later on, then I would prefer endometrial ablation.
The
Okay,
But
suppose
before
we
that, I
just
think
let
I
us
would
go
perform
very
alternately
LFT.
take the
systematically, right?
endometrial
Let us go
biopsy.
very systematically. We are looking at a very clear-cut reason for her menorrhagia. Let us deal with that focal lesion. As Dr. Upma rightly suggested, let us take an endometrial biopsy from a surrounding area. Let us see how the surrounding endometrium is. If it is normal, then it is most likely that she will respond to your hysteroscopic myomectomy. If not, let us re-evaluate. Let us follow her up with her menstrual calendar, and let us look at her and then later on decide if we need to do anything for that endometrium as a whole.
I think we can put a LNG also along with the, because it will
Exactly.
decrease
Yeah,
the risk of
ma'am, because
future
Possibility of
So
recurrence of
here,
the.
excuse me, here looking her age, we are doing hysteroscopy. Okay, by hysteroscopy, we are removing the myoma. That is a source of bleeding. But we should go for the endometrial aspiration. That is my view. Looking her age, because there may be association with the other pathology also. We can't say no, there's not required. But
Yes,
before
ma'am.
that, you can get the endometrial thickness also.
Truly, ma'am. So for this patient, the better would be to prevent recurrence along with hysteroscopic myomectomy, endometrial biopsy, followed by LNG IUCD can be put to prevent the recurrence, and that
Yes.
can be well explained to the patient. And we are already doing the endometrial sampling along with it. Okay. So next question. Parul, sir. Yes.
LNG
So
IUCD, still we will be a benefit because we have taken the endometrial biopsy.
yes, ma'am.
GL level A recommendation is endometrial ablation can be an effective therapy for selected women with type 2 leiomyomas and heavy menstrual bleeding who do not wish to become pregnant in future. So we are avoiding one extra surgery or an additional procedure for that. Okay. What energy system would you like to use? This I think has already been discussed. And here I have put up this video for one particular purpose only. This is something which I am doing. In Chennai, we had an IAG workshop, and this is a submucous myoma. What I now use is a myoma screw. What we do is we pass the myoma screw through the cervix without hysteroscope, and then put in a hysteroscope and identify. See, I have cut the endometrium over the fibroid, and then what discussion was about, see, this is the myoma screw. This is under vision of hysteroscope, but it is outside the hysteroscope. And then once we fix this, we start cutting around. And then what we call as teasing out can happen. Many times what happens when we pass scissors, the myoma escapes. It keeps moving. So once you have fixed it, then it becomes easy to dissect it from the base. Okay.
Yes.
This, I think, should we discuss this? Complications of hysteroscopic myomectomy? I think paucity of time precludes this discussion. Okay.
Okay.
Role of vasopressin, paracervical, fluid overload. I think we will jump over all this. Let us go to other cases because we want to discuss actual case scenarios.
Yeah. So she's a 28-year female, P0 plus L0, presents with infertility for 3 years. Ultrasound is suggestive of 2 submucous fibroids, 2 centimeter on anterior wall and 2.5 centimeter on posterior wall, and her bilateral tubes are patent. So now in this case, how will you proceed?
If the male factor is
If
the male factor is normal, she is ovulating, then we'll most likely blame the submucous fibroids because they're already 2 centimeters and 2.5 centimeters and they need to be removed. They change the endometrial implantation potential by increasing the amount of mucus, high estrogen,
And here the
endometrial
question is definitely we will be removing both the fibroids.
both the fibroids.
Now
because
the question is
one sitting
whether
or
we
two
should remove
sittings?
them in one sitting.
One sitting or 2 sittings?
Because that will definitely anterior and posterior is posing a very high chance of
So
having
Dr. Krishan
intrauterine
Kumar, Dr. Krishan Kumar just showed in his presentation that when there are 2 fibroids anterior posterior, there is chance of adhesion formation. So either they should be removed in 2 sitting or you're doing in 1 sitting, then you have to counsel the patient and you have to put some barrier in between either a Foley catheter or a hydroderase to prevent the adhesion formation. That's very
Nowadays,
important.
you get that there's a Cook catheter that you get, intrauterine catheter, which is a heart shaped, and it fills the uterine cavity nicely versus regular Foleys. Foleys may not be able to cover the whole surface area. So this is a heart shaped catheter. It's available in India now also. They're making copies of the Cook catheter, and that's a good intrauterine. I think you can do this and put the adhesion barrier.
Or put an adhesion barrier, hydrogenase.
So nowadays we can just do it in one sitting, while just not two fibroids, we can do multiple fibroids and something can be put inside. Along with that, nowadays we are putting hyaluronic gel as well, 1 to 2 ml within the intrauterine cavity. That is also acting like an adhesion barrier. And later on, now, sir, yes. Any role of relook hysteroscopy in this case? Is everyone doing relook hysteroscopy in such type of cases?
No, I think if she's collar back and if the scan looks all right and she's menstruating all right, I don't think, I mean, only if there is evidence of adhesions on scan would you want to go back in and see, I feel.
We just want one liner from everyone.
Yes,
One
I
liner.
think
If
we
the
have very
patient
good
is not
3D
having
scans and
problem and
ultrasound, so I don't think the second look is required. If you feel that you have done a complete job, then a second look should not be a requirement.
So one question, how can you detect adhesions on ultrasound?
And early adhesions, that too such early adhesions, unless they are calcified, then only they appear in ultrasound by hyperechoic shadows, right?
Thin endometrium, continuous thin endometrium post-menstrual.
That is very, I mean, you can say extensive case. Minor adhesions will never be picked up.
Never is seen, on ultrasound.
Sometimes we see cobweb kind of appearance in the endometrium with small
This you have to do
lesions.
saline infusions, sonography.
Yeah, saline infusion is an option, right?
I also agree with saline
scan, we will
sonography.
find intracavitary fluids, sir, sometimes loculated.
So if you have an office hysteroscope, why don't you put it in C and just with movement of the scope, you lyse
Then
those
you
adhesions.
break the disc.
Or else, yes, barrier gel if you have hyaluronic acid, that is good. And I believe all of you must be using estrogen.
Yes,
Yeah,
sir.
cyclically estrogen and progesterone, yeah.
But
High dose.
interposition seems to not be working because there is sufficient data to say either folic acid or IUCD, which we used to put in, it also has a risk of creating infection inside.
So that is intrauterine. I mean, that's the copper you're talking about, right? I mean,
after removing the copper, we used to put the
but
plastic.
that never covered the whole surface area. It left many areas bare so that
No,
adhesions could form. But
see,
this
the
new Cook
purpose
catheter,
was IUCD will bring about uterine contractions, and these contractions will not allow adhesions to form.
no, but
That
that is
was the purpose. Anyway,
that is the theory
it
of
is
that
now.
previous one, sir. But this present one is that it covers the whole surface area and doesn't allow two surfaces to oppose.
There is no need for whole surface. If they are away, little bit away, there will be no adhesions.
Anyway, so it is by and large given up. So let us give it up today also. And when should the patient plan pregnancy post-surgery?
2 months.
Here there are two aspects,
2 months.
hysteroscopy surgery and laparoscopy. Both have different plans.
So for hysteroscopy, it should be 2 months later, and for laparoscopy, it should be 3 to 6 months.
Okay, I think there is no discussion on that. By and large, we all accept that. We have 5 cases, so this is case 3.
Okay. So a 36-year female, P3L3 with history of heavy periods associated with severe dysmenorrhea. Ultrasound shows 2 intramural fibroid of 3 and 4 centimeter and 1 large subserous fibroid of 7 centimeter. How will you proceed and investigate the patient?
So here, fibroid mapping is must. She is 36 years old, and she has completed a family. So she has multiple fibroids. My counseling will be more towards.
This is the patient who is 36 years, para 3, L3. She doesn't require further pregnancy, but her age is still less, 36 years. So in that, definitely we can go for the medical method of for this purpose, because she is having severe dysmenorrhea, maybe associated with endometriosis. We don't know. And in that situation, we have to keep her the medical management for some time.
Ma'am, how long we will continue the medical management in a 36-year-old patient?
At least 6
going
months, minimum 6 months.
After 6 months, what will you do?
I think go for surgery straight away for her, remove the fibroids, and then maybe put in a Mirena for her so that recurrences are not there.
Yeah.
So
And again, do have a look in at the on the of the endometrium by doing an endometrial biopsy, just to see that there's no hyperplastic element in the endometrium that we are leaving out.
laparoscopic myomectomy is the thing which we need to do,
Yeah.
and then later
Yes.
on
For
the
the
next sitting
subserous
we
is
can.
okay, but for 3 to 4 centimeter intramural, maybe
Ma'am,
if
when
it is
we are
possible,
doing,
can you do?
But we are doing
Otherwise,
as well, remove the
4
7
centimeters
centimeter one, madam.
intramural, definitely we can
ma'am,
take out, ma'am. And if you have a doubt, you can bring the scan machine into the operation theater,
yes,
and
per
on table you
operative
can
scan.
put a
Yes.
per operative scan you can do and
Yes, we can do
Yes.
TVS.
locate the
And
fibroid.
that's why the mapping is needed, madam. Just prior to
yeah.
surgery, we need to do a TVS mapping, and we know we have got 3 fibroids, and removing them is not a challenge. So at 36 years of age, hysterectomy is not at all definitely needed. We cannot keep her on medical management for next 18 years. So many complications would be there. Laparoscopic myomectomy is the thing. That's it.
Yeah.
So
Followed by
myomectomy is an
LNG
option
units.
followed by. It's an option for women who wish to preserve their uterus or enhance fertility, but carries the potential for further interventions.
So even if it is straddling both the walls, you can see the endometrium is bulging there, but carefully you are going for full thickness closure. And if you dissect well, the endometrium remains intact. Rajesh insists on cutting the endometrium. I personally do not do that. He says that the blood collection can be drained inside the cavity of this myoma repair. I feel that if you do a good suturing, almost touching the endometrium, there is no dead space, and then it should be fine. What is
Yeah.
all of
But
your opinion?
no, I think, I mean, you don't have to cut it, but if it
It
happens,
gets
then we
cut.
don't have to be too worried about that we have cut it.
That is different.
No, I wouldn't want to, what do you say, prophylactically cut it.
Yeah, we do not open the endometrium, Dr. Parul.
Yeah.
Not required to open the endometrium unnecessarily,
Yeah.
I feel.
Yeah.
We can just make a small hole. I do the same. If it's a big fibroid and endometrium is popping up like this, we can make just a small hole so that small ooze and serous and blood and whatever is there, it can get discharged from the cavity. And the healing is
And
much
do
better,
the suction
especially if
while
the area.
performing the surgery. I mean, you can clear the field
No,
while doing the suturing.
when we are doing multiple myomectomies like this, and we have got a broad base fibroid which is touching the endometrium, and endometrium is popping up like that, it's always prudent just to make a small hole, even by a dilator, even sometimes can do. And it's not like injuring the endometrium like that. So it helps in draining whatever serous blood thing comes up. And then definitely the healing is much better. This is what we do. So hardly matters, I think. Sir, your
You're
screen share has
muted.
gone.
Dr. Uma, your mic is mute. You have to unmute yourself.
Yeah. So what I do is I put a Foley catheter, or I just put methylene blue to identify the cavity when I'm doing myomectomy. Because in a big myoma, sometimes you don't know when you have opened the cavity. And if you
Yeah,
want to open
methylene
it
blue.
intentionally, then also you should know where is the cavities.
Yeah, methylene blue can be pushed into just to see where it is,
Or
and
you can just put methylene. That helps a lot.
then if you cut it, you can see the blue, dye
Yeah.
coming
So I
through, and then
routinely put either Foley catheter with methylene blue.
yeah. But I think the
So,
debate is, do you cut the endometrium, on
No,
purpose or
I
not?
try to avoid her, but in case it opens, I suture it without taking the endometrium.
That is
we
another
are,
debate whether you have
think
to suture
when
it or
it
not.
is,
I don't suture it.
it's
Now,
actually
you need to
bulging, so it
suture
is
it.
very clear that this is endometrium.
sometimes, but not always
When
it is
Sometimes it is
very
not
it
obvious.
is
very
bulging,
clear.
it is very clear. So I will never like to open
We
it
are
and
cutting
do
Even
anything.
endometrium
I will
in
just
all
take
our
the suture and
cesareans,
leave it
madam.
like that.
Nothing to worry. We are
So I
cutting
believe
endometrium in all our
the
cesareans and suturing it
consensus is don't cut the endometrium
Yeah.
purposefully. By chance, if it
purposefully. Don't
gets
cut.
damaged, it
Then
is
it's okay.
fine. You avoid it in suturing. Now, we will not
Avoid
touch
suture.
upon retrieval of the tissue, isn't it? I think there is a consensus that it has to be a contained removal,
Remove.
isn't it?
Yeah. Yes.
Yes.
I was little bit worried about putting a ureteric catheter I don't think ureteric catheter is required, but all of you can say if very
Even
large
I don't
fibroid.
believe, because ureter is mobile, and when you put the catheter, mobility decreases. So your chances of injuring ureter becomes more when you're putting a catheter. So we are never putting a ureteric catheter.
Unless you have on your ultrasound that the ureter has been displaced or something like that, if it is a broad ligament, large fibroid. So
I'll try
it's a very, very rare
and then do.
situation.
So,
Very rare.
yeah, in days of, I mean, in the era of laparoscopy, I think preoperative stenting is, I think it was more of in the era of open surgery where you were not able to see the ureter, you do a preoperative stenting so you can feel it during the surgery.
Yeah.
But in laparoscopy, the imaging is so good, you're able to see see the ureter directly. So I don't think
No,
I
preoperative
use
stenting.
Damodar,
stenting
they
in
are
a
using
big
lighted
broad
ureteric
ligament
catheter.
pipe.
That
We
is
have
for
tried.
laparoscopy only, mainly.
You can see them. They are very nice.
Anyway,
Fluorescent catheter.
Dr. Renu will share with you the clinical pearls in this.
So these are the clinical pearls which has been given by FIGO 2020-25 guidelines, and they say if it's a pedunculated intracavitary lesion and patient is having AUB and infertility, always hysteroscopic myomectomy. Submucosal less than 50% intramural, always hysteroscopic myomectomy. Submucosal more than 50% intramural and abetting endometrium. Fertility definitely is affected without cavity distortion. Laparoscopic or open myomectomy can be done. If intramural and if it is significant, more than 4 centimeter, myomectomy should be sort of. So next. Next slide, sir.
So I would bring your attention to this. Open myomectomy is also mentioned here. So let us not take it altogether out of our purview. Okay.
Absolutely. I mean, there are some very large fibroids. I think you need to tackle it by open because, especially if she's for fertility, suturing the myoma and everything is very important. The myoma bed.
There are
Very
some very,
large and
there is very
lot of
some,
fibroids.
there are
Like if
some,
we have
multiple
30, 40, 50 fibroids coming up to the, Ziffy sternum. So it's always
Absolutely.
prudent to just open her up, and you literally have to fish down those 1 centimeter, 1.5 centimeter fibroids. And then practically, it is not possible to do it laparoscopically. Theoretically, we can claim whatever. And it is not, and again, the important thing is the suturing which is there. You suture it very well once you fish out all those, and whole cavity and whole myometrium is so much distorted. So open myomectomy definitely has a good role in a very huge fibroid and with multiple myometa seedlings and multiple myomas.
Yes,
And I think the basic take-home message need to be that a difficult laparoscopy and an inadequate kind of inappropriate kind of suturing, that is definitely much worse than the probability of adhesions after an open myomectomy. So that is where your skill and your expertise in that particular scenario, how well you can approximate the myometrium, how well you can strengthen that uterus and make it good enough to carry out a pregnancy later on, all that need to be taken into account. So an open myomectomy much better than a difficult laparoscopy and an inappropriate suturing.
True.
I have experience of removing 50 myoma in a young girl who has around 36 week size of uterus. So I did in open and the multiple size of 1 to 2 like 10 centimeter myoma. So sometime we have to go for. Thank you.
That was something which I wanted to share because I have
reduce the
seen
blood loss as well in open if there are multiple
Sorry to
fibroids and if
interrupt.
it's a very
Time is up. Can I request you to please wind up in 2 minutes?
Pratik, you had told us that you will have extra time.
Yes, sir. You have extra time. It is 7 o'clock. हमारा booking 7 बजे तक का ही है, sir.
So discussion on this. Each one of you can just mention your choice 1, 2, 3. First choice, second choice, third choice.
For excessive bleeding, tranexamic acid. And followed by LNG-IUS if the cavity is not getting distorted. If the patient is not willing for LNG-IUS, progestins can be given. The most recent ones still needs to be considered because we still don't have much evidence for those, the antagonist ones. If we need to reduce, I mean, she's anemic, then early acting like our Leuperoid depot and all can be used, the agonist ones.
Sir,
I
the
will
first
go
three
for
drugs, basically the tranexamic acid, the OCPs, and the progesterones, they are reasonably good for symptom control, especially to control AUB related to fibroids. But none of those agents are good enough to actually treat fibroids. So, no definite role as a definitive therapy for fibroids, but role only for symptomatic control or to tide over a crisis situation, or as we suggested in a type 2 myoma, to improve your surgical success with a hysteroscopic myomectomy. So only in those very transient kind of phases and scenarios where a medical management could be useful.
We can give COCs preoperatively till the patient is ready for surgery, or we do not want to do the surgery like in a younger. And post-operative, mifepristone works well if you want to prevent further, like just now doctor said she removed 50. I have removed 106 fibroids in a patient. So always give mifepristone in cases of multiple fibroids. And I have not tried Reluis. Reluis seems to be more promising. Let us see what it has to say in future.
These fibroids will pop out much more easily than a baby coming out of the vagina. So let us not give drugs and spoil all the planes and spoil our own surgery also is another point to be considered.
So I think for all of us, tranexamic acid is the drug for the bleeding. And when we want to reduce LNG IUCD, if it's not distorting the cavity, definitely is good. And now we have new kid on the block, that is GRH antagonist. I think Madam just said, Dr. Dinesh, regarding relugolix. So we have the combination now with 1 milligram ethylene estradiol and 0.5 milligram ethindrone. So with the add back, I think we can give it for 2 years, and we will have more literature, I think, in 2 years,
I just
1 or 2
feel
years time.
I've recently used Reluis on a patient where other methods, other medications are failing, and I put it for her, and within 4 5 days she continuously had spotting in spite of various medical management. Reluis I put in within 4 5 days it stopped, so it's quite quick to act also. And I mean anyway, all of these are just transient to buy time to for a
So
definitive
Reluase
management.
is good for
Is the
symptomatic relief in cases of menorrhagia. And
definitely.
just to buy, of course, to build up hemoglobin and to buy time
Yeah,
for
yeah,
surgery,
yeah.
not as a permanent.
We can
Now,
also
With
Young
the
let
liquid
us
treating,
It
you
can be
can give
kept
quickly
for
it
5 years.
two
So
years, 5
LNG
years
does
as
help in
well.
reducing
let us
the
quickly
size.
get on just quickly. 45 years female, P1L1 with no complaints, diagnosed with 4 centimeter subserous or even intramural fibroid on ultrasound. What is your advice to the patient? Come on.
Wait
Also,
and watch. Just observe.
wait and watch.
Observe. Yeah,
also
Just
How,
counsel
wait
the
and watch.
patient. That is very important. Although she is a 45 years age, still we have to keep the follow up, because
so
with the advanced stage there is maybe chances of different type of degeneration. If otherwise if she is not symptomatic, we can leave, only keep for the follow up. The
so
size
how frequent is the
shouldn't be.
follow up?
can do
I think
early
6 monthly,
Yearly,
six
yearly
monthly
or too early.
ultrasound,
No, no,
six
6
monthly
monthly too
ultrasound to
early.
see the size
Why
of the
yearly?
Once
Once
a
a
year
year is good
follow.
enough.
once a year. In the beginning,
Because
6 months,
patient become
3 months.
neurotic if you ask them to get ultrasound in every 6 months. 1 year is
No, not she will not be neurotic. She will be very happy, and we have to counsel because the hysterectomy is not indicated in that patient at
count.
So
all. But if the size
fibroids,
is
as
enlarged or
we
something shows the degeneration, in that situation we go for. In a subserous, there is sometimes there is a twisting also. In that situation, she can go for the surgery.
So
so
that
in
is
this
the, I
case
think,
we
consensus on that. That
med
even medical management is not required in these
Not
cases.
given.
Just follow them up, isn't it? So these
Yes.
are all the pearls. I think, Dr. Renu, I'll just move
Yes,
on.
sir. Just move on,
Uh,
please.
and the last case.
So she's a 40-year-old female, has a history of heavy menstrual bleed, ultrasound, 5 centimeter intramural fibroid, and patient is not willing for surgery. What will you offer to the patient?
So it's a small fibroid. We can go UAE, we can go for highly focused ultrasound or MR guided focused ultrasound. So
So
these options are there because
how many of you have used these modalities?
we have used MR focused. I have used in 2-3 patients. UAE, most of the patients don't agree, but she can go for UAE also. But how many kids she has is not written. They should have completed their family before they go for this.
So that part is true. She doesn't want anything. I mean, pregnancy or anything.
This endometrial biopsy, if she,
She is
even if
having
she's
history
not
of heavy
willing
menstrual bleeding
for
in that, because she's asymptomatic. So in
You
that
have to
situation,
rule
we
out
go for the
hyperplasia.
endometrial
endometrial
aspiration, and
biopsy,
we can use LNG
endometrial
IUCG also
biopsy
in this patient.
for
LNGIUS followed by
LNG
Yeah,
IUS,
LNG you
right.
can
Yes.
biopsy के बाद.
These are typically those patients who directly go to an interventional radiologist and without an endometrial sampling will get a UAE done.
No,
It
but
should.
with the 4 centimeter fibroid with the LNG IUS stay in the it might get expelled also.
Actually,
You might have
it's
to give
not
medical
distorting the
management for 3
cavity, it will
months,
stay.
If it is
shrink
not
the
staying in
fibroid
the
and then
cavity,
put.
it will not expel.
No, you
So
should
depending
not do
upon how
this
much the
procedure
cavity is
for
enlarged.
asymptomatic fibroid. Should not have done anything
The
because this is asymptomatic.
asymptomatic, symptomatic
No,
fibroid,
It
the
was
same one.
symptomatic. It was
Okay,
symptomatic. So you
children,
have
This
to.
is
can we
HMB,
have some
HMB.
closing remarks,
It is
please? So
symptomatic.
consensus and
Patient
closing
has
remarks.
heavy menstrual bleeding.
HMB hai, then we
Yeah.
have to go. Definitely.
I would put her on medical management, shrink the size of the fibroid how much ever possible, and then put in a Mirena.
So my question is, any of you have used these modalities and share your experiences? Because by and large, I think perhaps this may come up recently. It is coming up, no?
Yeah.
Photocoagulation with which
Microwave
energy?
ablation.
Huh,
Microwave ablation.
So
exactly.
actually,
Parul sir, these kind of cases, the gynecologists are not sending patients for UAE or other kind of methods. Now, gynecologists are in a position where they are managing complications after UAE being done for these kind of patients.
Fully agreed. So that is what I want to say, that most of these are, as of today, not very appropriate. I have seen complete necrosis and then second day hysterectomy.
Yes,
So one
this
has to
case
be
was
very.
a small fibroid.
Same. I have also seen one case with necrosis, and then she had severe pain for a long time, and then hysterectomy had to be done for her.
But I think this microwave ablation is something that's coming up. It is new in the market, and I think the techniques are getting fine-tuned. People before this didn't know, what temperature for how long and things like that. That's why we saw necrosis. But I've gone for a workshop, and they say that now the principles and techniques have been fine-tuned, and hence we don't see all this more often now. So I don't know. Personally, I have not used
I
it.
would like to share of one was my patient. She had uterine artery embolization. She's an 18 years girl, came in an emergency as a something coming out. So we thought she might be a pregnant or whatever, and she's not giving history. She expelled in at least 3-4 fibroid after this uterine artery embolization. And although we covered with the antibiotic and all this, ultimately she has become all right. But it happens because she came from the outside after this uterine artery embolization. So it happens.
So only a
Sometimes we can use
radiologist
many
after
times.
scan refer them for all these procedures, not a gynecologist.
I think Dr. Dinesh Kansal has an experience with microwave ablation. Ma'am, Dr. Dinesh Kansal, can you please? She has done few cases with microwave ablation.
Yes, we have done it for adenomyosis, about 5 cases. So the results are seen best after 6 months. So we are waiting for 6 months to be over. It's been about, say, 5 months. But we have not used it for fibroids. Fibroids, we feel, because either we go surgically completely, because ablations have their own issues. As Dr. Parul said, there can be a lot of adhesions. And in case you have to do any surgery in future, any pelvic surgery, you will be in a fix dealing with those bowel adhesions and everything coming together. So microwave is basically for the adenomyosis that we have used. Theoretically, it can be used for fibroids also, but we have not used it. So it's open to the house. Rather, I would go for OCPs. That may work. OCPs in combination with tranexamic in this case, that should help. Or maybe this relagolics, that is working wonders in these patients without any issues. And that's what the studies say. Again, that's a new drug and we have yet to see.
Only thing is, how long will you use them?
Because she's just 42. You can use it maximally for 2 years. So she's 42. So I
what
think
happens
Mirena
after?
will be a better off. LNG
And then I think putting in a Mirena for her would also benefit.
Would be a better option.
So as of today, I think it is the industry which is pushing all this onto us. We have to evaluate it carefully before putting it into practice. So I think our cases are over. Any questions from the audience we can take if time permits.
So I think we've far exceeded our time. Thank you very much to the very able moderators, Dr. Parul Kotadawala, our past chairperson, and Dr. Renu Singh Gehlot,
Yeah,
who has been convener for our
I
endoscopy course as well. I would request Dr. Sheila Mane ma'am to present her closing remarks.
I really like the discussion, the panel discussion, and the way Dr. Parul you puts it, and a relevant thing that nobody has spoken about the open. Very true. Okay. So all those points were brought out, and I'm sure that the delegates are really benefited today. I think it was a very good discussion in the panel, as well as all the speakers have really done a good job. So I think thoroughly, Pratik, I think we covered almost
Crash
almost
course in
everything.
myomectomy and fibroids in 3 hours.
I'm thankful to Dr. Renu for her slides and all the attention she gave to the panel. As I said, I was a little bit tied up in various things. I just shared with her some of my thoughts. Thank you, Dr. Renu.
I think
Thank
that
you,
is the
sir.
use of
Thank
having a co-moderator. It is better because all of us are busy. But I would like to thank everybody. I mean, the Dr. Parul, Dr. Renu, and all the panelists. And I can see your experience. And I mean, I'm a old timer, so I still remember doing open myomectomies for patients from Nigeria. And almost some 8 years back, we used to go get patients with 36 weeks, 32 weeks, 28 weeks, big fibroids. And as you rightly said, Dr. Parul, that reconstruction of uterus becomes easy. And such big fibroids, so we can't do because morcellation and all those things. So we have done it, I mean, very nicely. We could do properly, and the barb suture was used. So that is our experience. But I think starting with the classification, our new GC, youngest GC, I must say, Dr. Kanchan, we started, and everybody has really done a good job. It was a real feast watching videos, everybody's videos, Rajesh, Vidya, Dr. Krishna Kumar, and Dr. Sujata Mishra talking about medical management, and Dr. Archana showing the importance of the ultrasound, and everybody has really done a good job. And thank all the chairpersons as well, and Dr. Ritu and Dr. Richa for coordinating this, and Dr. Sarita, even though she was late, she could join. So we are all ICOG here, thanking you all for this excellent session. And thank
Thank
One
you,
you.
ma'am. Can
interesting
I
aside,
request?
let
Inviting,
me
madam.
share. Pratik,
Yes, sir.
today morning I was called in by a young colleague who is at least 12 years post PG, excellent endoscopy surgeon, one of the IAG committee member, but patient unmarried girl having 11 centimeter fibroid. So I suggested to him that instead of laparoscopy, do it open way. She has entire obstetric career ahead. So he said, I have no experience of open myomectomy. Please come and do
Not
it for
allowed.
me. So
We
So
have
we will
coming
always
open
be
to
in
this
demand. We old
extent.
timers are not going to go away quietly into the night.
So market is still there for us.
Can I
So
request
Dr.
Dr. Richa
Parul,
Singh and
Dr.
Dr.
Parul and
Ritu
Pratik,
Khanna?
there is
Uh,
Yes,
one
ma'am.
question everybody is asking, whether we get ICOG points, whether we get certificate. I think we the office bearers have to discuss about this. We'll talk
Yes,
about
ma'am.
it later.
I
We'll
think there
discuss
is
that.
a protocol on this. So maybe Pratik can look it up, how much and in what manner.
Yeah, that's
Done, sir.
what we will look into it, because physical we were giving, but now there is a demand for this also. So we'll see. I think our core committee, all the past chairpersons, we will discuss this. Yeah.
Thank you, ma'am.
Yes.
Can I request Dr. Ritu Khanna and Dr. Richa Singh to present their closing remarks, and then I can do the official vote of thanks.
Thank you, Dr. Parul and Dr. Renu, for such an excellent interactive panel discussion covering all the topics, and the panelists who made it more interesting too, because with the different views, different thoughts, and which made the discussion so interesting. So, a very wonderful discussion, and indeed, it was a crash course on fibroids, starting from mapping to the endoscopic management, and then to the a wonderful panel discussion of different case scenarios. So I congratulate Sheila Mane ma'am, Pratik sir, and Sarita ma'am, Sadhna ma'am, and all the ICOG office bearers for this excellent webinar today, this masterclass on fibroids.
Thank you, Dr. Richa. I see Dr. Ritu is not there, so I'll present the formal vote of thanks. As the ICOG Secretary, I'd like to place on record my gratitude to our FOGSI President, Dr. Bhaskar Pal, who joined us despite his busy schedule. Thanks also to Dr. Sheila Mane ma'am, Dr. Ashok Kumar, Dr. Sadhana Gupta for giving me this opportunity to organize and get all of our GCMs involved in these two programs, both yesterday as well as today, and giving me a free hand. Thank you, Dr. Suvarna Khadilkar, for joining us despite your busy schedule. The convener, Dr. Sarita Bhalera, was able to join us a little later. Dr. Ritu Khanna and Dr. Richa Singh have done excellently behind the scenes. We've had fantastic speakers, both for the medical management as well as the basics and the advanced laparoscopic, hysteroscopic, as well as difficult myomectomy, which was demonstrated in more than ample detail through a variety of wonderful videos. Thank you to our chairpersons. I must make a mention specifically of Dr. Kalyan Barmade, our president of IAG, who took time out and was with us. Dr. Kiran Pandey, who is one of the leading lights of OBGYN in India. Dr. Mahesh Koregol, we look forward to seeing you as an ICOG GC member very soon, hopefully. And a fantastic panel, which unfortunately, I was the devil's advocate and I had to cut that short because we were over time. But Dr. Parul Kotadawala and Dr. Insin Gehlot, along with these wonderful panelists, did more than justice to the task at hand. It's only unfortunate that we can only do this for 3 hours. Maybe we should look at increasing the time duration in future, and hopefully we'll be
Should
able
be
to
1
have
hour.
certificates, as well as we'll be able to have ICOG credit points in the near future. All masterclasses are either in the 3rd or the 4th week of the month. So the next one will be around 20th of February or just after that. We will keep all of you informed. Thank you very much, audience, who tuned in such huge numbers. We had more than 250 audience at one point of time, and we look forward to seeing your continued cooperation and your inputs for future activities of ICOG. This is your organization. We are merely here as office bearers in the seat for 1 or 2 years. We require you to cooperate. We require you to be part of this activities, and we look forward to your continued cooperation in future. Thank you very much for being with us today. Thank you, backend team. Goodbye and God bless.
Thank you so much.
Thank you, everyone.